And that way, anybody who's absent, I put it on private YouTube channel. They can't get to it without my YouTube code. And then if you want to, right now, if you want to pause recording so that it's not, just filling up dead air, you go back over, pause. No, not pause share, pause recording. Under more. Under the more button.
Recording. All right.
And then anytime you take a break, you can pause it.
Okay.
Leonard says good morning.
Good morning. All right. Good morning, everybody. Thanks for joining us. My name is Max Patterson. I'm really thankful to be given the opportunity to do this. As is customary in these things, I've put together kind of a quick, now you're not working. Okay. Oh, nice. All right. Quick vanity slide, kind of who I am, how I kind of got to be up here today. My name is Max Patterson. I'm a paramedic with Durham County EMS. Additionally to that, I've got some interesting side jobs that I do with them. I am a tactical medic with a number of Durham teams. The Durham Police BCERT team, which is a biochemical emergency response team, as well. I'm a TAC medic with the bomb squad. And both of those two together sees me going around the country a lot to a lot of interesting places, to see a lot of interesting classes and learn a lot of different and interesting things. In addition to that, I am an instructor for a whole ton of things, as well as a federally certified hazmat technician. I was contributing author to Avoiding Common Pre-Hospital Errors. Back up there, you can find I've got my own chapter in there. As well as just a bunch of other general stuff that I am affiliated with and do. I guess the long story short, I'm a street medic that does a lot of stuff with hazmat and bombs and WMD, and I get to play with a lot of really cool people, go a lot of really restricted places, and get to see a lot of restricted stuff, which kind of plays into it. And somewhere along the line, you learn to really, really like it. Right. So today, the whole point of today is just generally WMD awareness. We're going to cover a bunch of different questions about that, relevance of that to medical providers, because I know it's a big question that a lot of paramedics have. When we do initial education, we stuff WMD stuff into the back of the book. It's maybe the last 2 or 3 pages when everybody's already checked out. And then, you never really study it going through your career unless you have a reason to, unless you're particularly studious, or until something bad happens. So we're going to talk about the relevance of how WMD awareness is important to us, regardless of whether you're on a helicopter, whether you're on a critical care transport, whether you're on a street, or even whether you're working in the emergency room as an adjunct with that. We're going to go through the various CBRN classifications. You're going to see those CBRN a lot. If you Google it, you're going to get pages and pages on it. That's the general classifications: chemical, biological, radioactive, nuclear, explosive. All of your WMD, non-extern, encompasses all of them. We're going to go through each classification, hit a lot of the highlights that are in there, talk about some of the big bads that might be lurking at the different classifications. Pathophysiology of the victims of a WMD incident. Obviously, it's going to be agent specific. We will talk about kind of what's going on with the patient, what we can expect to see, what we're going to have to do about it. And again, what you'll find as we walk through this is that it really doesn't matter where your role in the continuity of care of these patients is. The patient's going to require the same amount of care, whether they're on the street or in the ICU. Barring a few very specific individual exclusions to that. Discuss PPE when dealing with the patients of a WMD incident. Again, it doesn't really matter which part of it. Obviously, me going into the hot zone, I'm going to have to wear a different thing than somebody in the decon corridor, than somebody in a transport service, than somebody in the emergency room. And we'll talk some of the guiding principles of that and some of the overall components of that. And then we're just going to talk about the role of critical care in a WMD incident. Again, this kind of the relevance. Why does it matter to me? What am I going to see about this? And it might surprise you if you've thought depending on how much you've thought about it, but the high likelihood is if you're involved in any way, shape, or form with a vehicle that is able to transport patients in any way, shape, or form, you're probably going to get sucked into one of these if they have a lung. So before we begin, general disclaimer, obviously I'm going to be talking about some general dosing, some general guidance for medications with this. However, just because you saw this in a slideshow presentation one time does not authorize you to start doing some of this stuff. So please follow your local protocols at all times. That said, there probably isn't a huge amount of variance with them, because even if you go through the CDC and the FDA, and we'll talk a little bit about the CDC recommendations on some of this stuff, it really doesn't matter kind of where you are. The recommendations are going to be the same. And additionally, some of the pictures in the video that we're going to have in here might be hard to look at. It might not be, depending on how stone cold you are or how long you've been doing this. Some of the rougher stuff I couldn't get in here, but to give you an idea of what it looks like for patients that have these disease process, have these exposures, and have the diseases going through. We'll talk about that. So let's talk about overall what is WMD, because it's a wonderful word in the current zeitgeist. It gets thrown around, obviously much more so in the last decade and a half. The search for WMD, the not finding WMD, the maybe we found WMD, the well, there's this, which is technically classed as WMD, and kind of how that all goes together. So what you're looking at right now is straight from the FBI website. It's the legal code, Title 18 code of what a WMD is. So as you can see, reading through that, any explosive incendiary poison gas that is basically designed to kill people. Any weapon that's designed to intend to cause death or serious bodily injury through the release, dissemination, or impact of toxic or poisonous chemicals or their precursors. If you're not familiar with precursors, we'll kind of go through that as we go through. Any weapon involving a disease organism, and any weapon that's designed to release radiation or radioactivity at a level dangerous to human life. So again, the point is one weapon that we can use to kill a lot of people. Not really happy stuff, not really fun stuff, but it is the world that we live in. Interestingly enough, though, if you go back to about 600 BC, in Kira, Greece, Athenians were the first people to deploy WMD during a siege of the city. They used a local plant, put it in the water supply, and it was pretty effective. So when we're talking about WMD, we're really talking less about current political climate, current geopolitical climate, more about humans. I mean, the interest in how do we kill more people faster has unfortunately been a hallmark of the species for a very, very long time with that. So am I going too fast? Is everybody able to keep up, the folks that are listening?
You're doing good.
Okay. All right. So CBRN, I kind of mentioned that a little bit ago. WMD classifications: chemical, biological, radioactive, nuclear, explosive. There is a distinction between the radioactive and the nuclear, somewhat, in terms of what we're going to see. We'll cover that. I do have them comboed together here just because it's easier to hit on both at once. But they do have enough distinctions that they are worth their own individual categories. So we'll start with chemical and kind of work our way through that, because chemical is the big one. If you think about the big scary stuff that keeps people up at night and that you're most common to see, it's probably going to be in the chemical, because chemical agents have a tendency to be really, really easy to weaponize. And by weaponize, what we mean is you take an inert chemical or an active chemical and you put it into a shell, you put it into an aerosol can, you give it a delivery system so that it moves from the test tube out into your chosen demographic of individuals that you wish to punish, as it were. So your main chemical agent classifications of the chemicals, they can come down, they classify into nerve agents, vesicants, blood agents, choking agents, riot control agents, psychomimetic agents, and toxins. And we'll cover through each one of those, as I mentioned, and go through kind of some of the big stuff, big with them. A lot of it, if you're looking at this list, and maybe you've never really been interested in WMD or CBRN stuff before, but I can promise you most everybody is able to look at some of this stuff and be like, I know somebody from this category, I know somebody from this category, even if you've never necessarily paid attention to it. So we'll start with nerve agents. And nerve agents are they're almost the scariest on this list. I would say they're probably the ones that you're going to see the most. Your traditional organophosphates, the way that works is a nerve agent. So in this list, you've got Sarin, you've got VX, you've got Tabin, and you've got Soman. GB, GA, GD. The pair of letters that you see there is a generational distinction. If you can picture a mad scientist, quite possibly of either German or English descent, alone in a lab with thunder and lightning going on outside as they're trying to create the perfect method of killing a whole bunch of people, sadly enough, you're probably not too far off because they found and identified a lot of this stuff following the Second World War and the First World War on some of the other ones in the category, but they just needed a way to label them. Then they developed names later, kind of as they move through. The pin, that's just a standard pin, the type that you'd have on your clothes. I've got the pin there because the concept of the pinhead, if you've ever heard the expression, how many angels dance on the head of a pin, when we're talking about any of these nerve agents, especially Sarin and VX, which are far more advanced from a weaponization standpoint, the amount of chemical, Sarin or VX, that you could put on the head of a standard pin would be enough to kill a room full of people. And it wouldn't be pretty, but it wouldn't be reversible either. The toxicity of these compounds and the small trace amount that's required with which for them to do their business is scary. So the pinhead analogy, if you're trying to think about how much it would actually take to kill a ton of people, the head of a pin is more than enough. If you hear a pause, that's me drinking coffee. My brain is regulated by caffeine and nicotine, so it's not your connection. It's just me keeping my brain chemistry intact. So, no. So let's talk about Sarin. Sarin is one of the more popular, the designer. Your designer ways of killing people, but it's also one that's been in the news a lot because it is very effective. It's very easy to get, and it's very easy to weaponize. So walking through basically how it works, you've got a picture on the left that's showing your the acetylcholinesterase, ACE, and the various inhibitors and what goes on when Sarin works. And it shares this function with most everything on the list. It shares this function with your standard organophosphates. But essentially what you're seeing is that the Sarin blocks the enzyme responsible for releasing off of the receptor, which basically means your muscles, your nerves, and your everything gets set to an on position and do not stop. They do not relax. They do not do what they're supposed to do, which is a problem because if you think about some really easy way to kind of figure out how this works beyond just the chemistry, if you flex any muscle that you've got, whether it's been, you did arm day or leg day yesterday, but if you just flex that muscle and keep it flexing, you're going to start to feel that pain. You're going to start to feel that muscle failure that builds in. When you have Sarin or any of these nerve gases taking effect, what's happening is that muscle gets set to a flex position and is unable to relax. Unless we act on it, that's how it kills people, because every single muscle in the body is going to experience that from top to down. So your diaphragm, your GI tract, your heart, all of this stuff, all of the stuff inside you is going to do that. And that's where we get into seeing all of the excretions, the seizures, the convulsions, the loss of respiratory drive. It is a terrible and horrible way to go. Absolutely. The good news on this one is that we can actually do something about it. Many of the ones that we'll talk about today, there is nothing that we can do except for sit back and watch and provide supportive care. We don't really have reversal agents, and we certainly don't have them in the field in many cases. But on Sarin and VX and a couple of these other ones, there's actually something we can do, and we'll get to that in a moment. Sarin is kind of, as I mentioned, it's a very popular one. 1995, the Tokyo subway attack, an individual carrying just a briefcase that had a cup in it with this was able to release it into the subway during rush hour. And you can see just that small amount he had was enough to cause over 1,000 casualties. And if you've ever seen any videos of the Tokyo subway system, yes, it's something to see, but you can see very quickly how you could get that many people quick. But in terms of total deaths, there was only 12. The plus one, there was an individual who died about 14 years after the incident that had been ICU for 14 years after being exposed with that. And the individuals that count up and attribute casualties, they were not entirely certain whether they should classify him with the 12 because I guess 13 is just too much to go. But he died as a result of that. For political reasons. The biggest thing that we've seen is we've seen it used time and time again over the last 5 years in Syria. Now, I'm not going to stand here or on the other side of your screen and get into a political discussion of any source, but I will say we have detected sarin nerve gas in the populace at the site of a lot of attacks in Syria over the last 5 years. And these are multiple sources of data, multiple sources of detection that have hit positive for sarin. Unfortunately, getting the actual death toll and the affected because of the political state of the country has been difficult. We know it's at least 500 have been killed by it, mostly women and children, mostly in shelters. And affected again 5,000 again mostly women and children, and mostly in shelters. And the reason why is because they're so used to any place that's so used to having like air raids. What do you do if you hear the air raid siren go off? You go into a shelter, a concrete bunker, something that's reinforced. And unfortunately, because the shells contain sarin, sarin's heavy, will kind of stay low to the ground. It goes right into those shelters and just kills people wholesale. There is a ton, if you are interested when this is over, there is a ton of terrible, horrific video out there because, of course, last 5 years, everybody's got a cell phone. Everybody wants to Instagram the apocalypse, as it were. You can actually see a lot of these cases. It's hard to watch, but if you've ever kind of wondered, hey, what does it look like when somebody gets killed by this? It's not that hard to find out. And having the medical understanding of what's going on a physiological basis does give you the ability to kind of look at that and go, oh, that's the sludgeum. That's your classic organophosphate symptom poisoning. We'll cover the sludgeum mnemonic here in a little bit. But that's what you're looking at. Sarin is very much still in play. Of everything on this list, from a creation standpoint, you take your mad scientist in a lab that's sufficiently motivated. It's really not hard to create sarin. It's not hard to weaponize. It is just one of those things that we're going to see and hear from again. Does anybody have any questions on this one before I move on to something else?
I got one question.
Yeah, go ahead.
So this is technically the opposite of succinylcholine.
Yes. You know, I don't want to necessarily say yes, it's the exact opposite, but it does act against it, yeah, and neutralizes it, which is, and that's what you got.
Thank you.
Yep. So that's why we've got those 2 PAM kits. That's why we've got the atropine. That's why it works. And we'll cover that a little bit. But yeah, if you want to think about it like that, it's certainly not an inaccurate statement. All right, let's move on to VX. Of the stuff that makes people like me terrified, VX is the top of the list. It is the most toxic chemical weapon known to mankind. I say as of 6/11/2019, because if history has shown us anything, is we're good at killing each other. So if somebody's watching this a month down the road, they could have found something else. But I checked this last night at about 10:30, and it's still top dog. What is terrifying about VX? It is much more viscous fluid. It's much oilier. It's much hardier. And it can persist in the environment for days. Sarin has a pretty low evaporation point. It's going to come in, it's going to do its business, and then more or less go away within a reasonable amount of time. But VX is going to hang out. It's going to cover everything. And it's going to be, depending on the environment, if it's colder weather, it can survive for months. And while it's surviving, while it's persisting in the environment, it is still just as deadly as it was when it was first delivered. Third little point down there, certain Eastern Asian country, more Southeastern Asian, has over 5,000 tons of this that we know of. So if you ever kind of wonder why everybody is kind of focusing on this Southeast Asian country with a bit of unstable leadership, I think we could say, it's because they have more than 5,000 tons of the most toxic chemical known to mankind, and this stuff is really easy to weaponize. So you can imagine from a military and a political standpoint, you probably want that stuff under a little bit tighter control than it is now. Just saying. VX has been used before. Again, where this one pops up, interestingly enough, is small little doses. Again, going back to the head of the pin. There was an assassination attempt, actually a completed assassination, as you can see in the little diagram there, of the brother of a North Korean leader, was killed with VX in the middle of an airport. And from somebody who understands how VX works and understands it, the idea that you would deploy that in a foreign country in an airport is insane to me. Yeah, they managed to get their target and nothing else, but that's how easy this stuff can get out there. So if you look at the properties of it, it's oily, it's odorless, it's tasteless. You're not going to know it's there. It will mix with anything. As far as exposure, basically being human will get you exposed, whether through your skin, through your eyes, vapors, or ingestion. And as you can see, the symptoms will immediately work. And how it works, very similar to sarin, very similar to that anti-cholinesterase. And then you get the constantly stimulated. Respiratory failure is one of the more common things that you're going to see on these patients, next to the seizures and the copious secretions. But respiratory failure is definitely one of those things that you're going to see because the diaphragm's not working, the intercostal muscles aren't working, so there's no ability to keep that negative pressure system working. In terms of symptoms, huge amount of different things that it can manifest as: confusion, drowsiness, headache, and you can read through that. Basically, pay attention to everything. Abnormally low or high pressure, slow or fast heart rate. Again, different people are going to go on this ride differently. It is somewhat dose dependent, whether you're going to see the slow or the fast or the low or the high. Typically, the larger the dose is when you're going to get into your bradycardias, where you're going to get into your hypotensions. The more trace doses, still lethal, but trace-ish, which is not a word, but it is now, is going to get you that fast heart rate. It's going to get you that high blood pressure. Abdominal, GI, everything. And then excessive sweating, muscle twitching, as you see there. And then just that note in the bottom, exposure to a large dose by any route may result in convulsions, loss of consciousness, paralysis, and respiratory failure, leading to death. One of the things that we as patient care providers, that respiratory failure is one of the common themes that you're going to see across everything else, most everything that we do here, where that respiratory drive decreases, where the ability to perform that active respiration, keep moving that chest it goes away. So honestly, the bag valve mask in a vast majority of these patients, or an intubation, or however you want to do it, that's going to be the one big thing that we can do. Be aggressive about that. Get out there with that. That's the kind of the one big thing. So that's Saren. That's VX in a nutshell. Does anybody have any questions on VX before we move on? Okay. So the other two categories, other two nerve agents in that, the TAB and the SOMA, physiologically, they're going to affect people the same as Saren and VX. Because of chemistry, because of the way that they're manufactured, the way that they maintain stability, they're really not as practical to create. They're not as practical to deploy. It's harder to weaponize. It's harder to get them to disperse. It's harder to get them to not vaporize. So the likelihood, these are more theoretical concerns than something you would actively see or even actively expect to see. Simply because there's one, VX and Saren are so much better at it in every category, from lethality to weaponize, the ability to weaponize it. There's, if you own a Lamborghini, are you really going to drive that Prius? It's the same kind of thing applying to that. So any of your patients, and I say any, I really like to avoid broad sweeping generalizations because there are exceptions to every rule. But in this case, anybody in the nerve agent category is going to present with that classic organophosphate poisoning presentation. And depending on how your initial education or just the education you've picked up in the career has gone as to how aggressive you are thinking about organophosphates when you see kind of these cases that are just going to hell and you're like, what is going on with this patient? Two mnemonics there, Sludgem and dumbbells. There seems to be some variety in terms of regional bias as to which one you may have been initially trained on, which one that you are more familiar with. They both do the same job. I'm not going to tell you one is better than the other. Personally, I keep Sludgem in my head because it's a lot easier and it's a funner word than dumbbells, which I might be using to describe any number of individuals at the time. But there's your salivation, lacrimation, urination, defecation, GI disruption, emesis, meiosis. On the Sludgem and dumbbells, you can see there, has a couple of extra things. It adds in the bronchospasm. It adds in the bradycardia. Again, the asterisk on the bradycardia is that it's going to be dependent on dose. It might be tachycardia. One of the things I like about Sludgem is, without being overly crude, if an orifice can excrete any sort of substance, it's going to in these patients, whether it's vomit, whether it's tears, whether it's sweat, whether it's saliva, whether it's a combination of all of them, urinary, fecal, it's going to come out just because it's the way that everything is turned on and nothing is able to be turned off. So that's where you get that really classic, these patients are very wet, they're convulsing. When you see one, if you have the misfortune of seeing one in your career, you see an online video, very similar to what Andy Warhol spoke about art. You'll know it when you see it. You might not necessarily put it together because, of course, we don't see a lot of VX and Saren, but organophosphate poisoning is actually something that, if you look on the right, if exposed to any of those, they all have the same properties. They all attack the body and are metabolized by the body in the same way. And yeah, those are stock photos, but I certainly could take a very similar photo of the shed in my backyard of just various things that I've kept around to kill critters. If You see the Raid Flying Inspect spray. If you've ever kind of been chasing a wasp around the house, trying to spray him and he moves, and then so you go over here and you spray him again, and you're leaving these little clouds of behind you, and you kind of, maybe you walk through a cloud, maybe you're not paying attention, you're like, oh, this sucks. And then you hate the wasp more, you redouble your efforts, and eventually you kill them with a shoe. But not after leaving behind a couple of these clouds. But if you've ever had the misfortune of accidentally inhaling one of those, and that kind of feeling of, you start salivating, your eyes start watering, that is it. That's what's happening. Now, from a concentration standpoint, it would take a lot of direct ingestion on a lot of these to really present with the classic nerve agent to truly be a life-threatening emergency. I'm not saying you're not going to be miserable, and I'm not going to say that if you're some certain parts of the populations may be more susceptible to it than others, but typically, no, we don't sell nerve agents, weaponizable nerve agents over the counter, but we do sell their little cousins, and kind of go through that. But this is really common, and especially in areas that have a lot of farming. They still use a lot of anti-pest. Specifically, if you've got any sort of insect that's got a hard carapace, your cockroaches, your ants, vertebrates, they're going to use something else for, which we'll cover a little bit further off, but your rodents, your possums, your rats, and stuff like that. But it's not uncommon for these industrial facilities and for a lot of these farms to have stuff like this on hand. So the possibility of seeing somebody get into a misadventure by farming and present with a nerve agent presentation to the organophosphate is actually a lot higher. And it's certainly a little bit more common than the weaponized format of it here. But that's not to say it can't happen. This stuff is out there in massive quantities, kind of covering everywhere. And some of it might surprise you. We'll talk about that here in a second. So when we talk about nerve agent treatments, really there's the two big things. You're going to want that 2PAM kit, the Mark II kit, the Duodo kit, whatever it's called, whatever version that your agency has. You should have these on every land ambulance and probably on every air ambulance as well. A couple of kits for personal use, but it's got the pralidoxime and the atropine in there. In terms of your nerve agent treatments, this is the hallmark for treatment, and honestly, the only thing that's really going to work from a symptomatic relief standpoint. Now, the 2PAM kits that we tend to carry, again, service-specific, agency-specific. I don't want to speak in globalizations. I know any of the agencies that I've been affiliated with or worked with, those kits are for our own personal use. They're not particularly, they tell you, don't use them for the patients because you might need them yourself. That said, you're going to do what you got to do. But typically, we don't carry these kits around with enough volume of it from a treatment standpoint for the patients. They tend to be more, single use for us to buy us enough time to get from wherever the bad stuff is to wherever the not bad stuff is. And to break it down a little bit, and again, please see the disclaimer in regards to follow your local protocols on how what you're actually going to deliver for dosing of it. But the loading dose from the CDC recommendations, the loading dose of the pralidoxime, 600 milligrams. That's your initial, hey, you've been exposed to something. Here's your 600 milligrams of that. As well as the loading dose of the atropine, 2 milligrams advised. So what the atropine does, I'm going to kind of, I don't want to get dizzy here, but the reason we're giving atropine in these patients, and I'm going to scroll back to here, is that the atropine will actually neutralize and release those neurotransmitters. It kind of bumps its way in as it allows that neurotransmitter to open up briefly. It does not defeat the influence that's caused by the sarin, but it does manage to sneak in there and open up that neurotransmitter, which allows for a kind of a momentary relief. The only way to get the sarin out of the body or the VX out of the body is to allow the body to metabolize it over time on its own, which is a terrible, horrible time. But the best thing we can do is we keep hitting that atropine in, which keeps buying you those little windows of breaks. And that's why you're going to have that 1 milligram of atropine Q5 until the symptoms reduce. So again, this is CDC recommendation. Follow local protocols above all else. I worked with a medical director one time who had a particularly terrible case of organophosphate poisoning brought into her ER from a farming accident. And it took 3 days of Q5 atropine to keep this person alive. And she actually took a picture of all the atropine boxes because, let's face it, we have dark humor, and somewhere along the line, someone had the idea of let's just stack the boxes up in the next room just so we can see kind of where this is going. And as the room was pretty much full of it, full of boxes of atropine. The patient lived, the patient recovered, but it was a 3-day struggle of constantly getting that atropine in there to open up those receptors to relieve that stress off for the symptoms to clear out. And how long the symptoms are going to, there's no guideline for how long they're going to be symptomatic. It's going to be dependent on how they were exposed, how much they got, maybe intrinsic factors in regards to their own personal health, their own personal metabolism, things of that nature. You just got to keep watching. And if they're still symptomatic, then we're still fighting. We still got to repeat that atropine. Interestingly enough, for the CDC recommendations, once you get through that initial dose of the pralidoxim, that's it. You're not repeating that. You're just repeating the atropine over and over again. For the seizures and for the convulsions that these patients will have, diazepam and Versed, midazolam, is effective for that to a point. It works, tends to have a much more of an effect on the smooth muscle than some of the other types, but it is able to provide relief. But that atropine, that is the most important thing that we can do, and bag them. Bag them copious amounts of fluids to make sure we keep that blood pressure up, as well to kind of dilute it out a little bit so that as the organs are processing through all of this, they're able to deal with everything in smaller doses and smaller bite size. So that's kind of the general overview of the nerve gas segment of this. We're about to move on to another class. Are there any more questions or anything that you would like cleared up here before we move on?
Yeah. If you have a pediatric patient, is the treatment the same as an adult patient?
So that's going to be, so the concept of treatment is the loading dose of atropine is going to be lower. CDC has various recommendations, various state protocols have recommendations on it. You're not going to give 2 mgs of atropine to my 8-year-old daughter, for instance. It's probably closer to 1, but it does tend to be weight-based. But yeah, the goal is the same. How we're going to get to the goal is the same in terms of the drugs we use and how we choose, but the doses are going to be lower. Go ahead, sir.
That's a copy of that. Gotcha.
Okay. That said, when we talk about a 2-PAM kit, it's, again, protocol specific. I know mine has that kind of exception there that, if you've got my 8-year-old daughter has been exposed to this and all I've got is a 2-PAM kit, guess what I'm doing with that 2-PAM kit? Whether it's that if she gets overdosed on atropine, I would much rather that than what's going on. So there is a certain amount of, you got to do what you got to do because there's no pediatric 2-PAM kits out in the field. We certainly don't carry them. But local protocols will trump all. All right. Anything else? Cool. All right, let's move on to vesicants. These are the nasty ones. Sarin and VX will kill you in a very short amount of time. Unfortunately, the ones in the vesicant category are going to probably make you wish you were never born. You've got your major ones here: lewisite, nitrogen mustard, sulfured mustard, and phosgene. The mustards get kind of classified all together. They're all mustards. how they get mixed, what form they have. The end result is the same. So we're just going to talk about mustards as a topic, but there are two subgroups to it, but we're just going to cover the one. This is you're looking at a World War II advertisement, kind of poster that they would have up, and they'd have around army camps, or they'd have around civilian populations, because mustard does smell a lot like horseradish. So if you smell horseradish, it's bad. And I'm not entirely certain everything that's going on in that picture. However, it is funny to me because the mask and the horseradish. So the mustard gases, by far, have been the most prolific chemical weapon that has ever been used by humans on humans throughout history. And it goes back to World War I, when the Germans were the first ones to kind of deploy it. They deployed 80,000 tons of mustard gas on a coalition of UK and Canadian soldiers, which was the first documented case of mustard that was utilized. Of all of the weapons here, it's got the non-fatal casualties. It's got certainly the most total non-fatal casualties by chemical weapon. Now, it's worth noting non-fatal casualties because the goal of all of this is to get the other people to stop fighting you, right? If you can incapacitate their force, it's the same as killing their force. So mustard gas is really good at incapacitating and kind of driving people out of areas. There's no antidote to it. There is nothing that science has ever created or possesses currently that's going to reverse the effects of the mustard gas. So treatment is simply going to be get them out of wherever they are, get them cleaned up, and then support what they see. Causes apoptosis, whether it's inhaled, whether it hits the skin. That's what you're seeing when you look at the that's a mustard gas exposure, but you see those giant pustules, you see the sloughing of skin. And if you kind of go back to anatomy and physiology, apoptosis, the arch enemy of necrosis, which is the kind of the more natural state. But when that cell erupts, it causes its neighbor to erupt, which causes their neighbor to erupt. That's why it's so effective, and that's why all it needs to do is hit any cell on a human being, and it's going to pop it, which creates that skin appearance to it. If you inhale it, it's the same thing. It's just going to be internal. So the airways on these patients potentially could be really nasty, really difficult. Definitely going to require aggressive management of intubation, RSI, if you can, to kind of protect that and make sure that you can at least keep the airway clear. Effects are not immediate. Again, because this is typically deployed in concept of a gas over top of a populace or in a populated area, it's hard to have one, hey, mustard gas is going to take 5 minutes to take effect. That's not true. It's going to really depend on how much you get exposed to, but the effects tend to kick in between 5 and 15 minutes after the fact, so you have some time to think about what's about to happen before it happens, but you also have time to run, and that was why they kind of had to push for, if you smell like the garlic, if you smell the garlic, get out. If you smell that horseradish smell, get out of there. And again, it can affect the skin or the respiratory tract. But mustard, huge amounts of history to its utilization, huge amounts of casualties that's been caused by it. It's relatively easy to defeat with proper gas mask and proper PPE by today's standards. But if you look back at the World Wars, those concepts and everything, we knew gas mask. We didn't necessarily know how to cover up as effectively as we do today. And then the other guys kind of hanging out in the class of vesicants, lewisite and the phosgene. Again, these tend to be theoretical concerns. They are compounds that have been weaponized. They are compounds that have been created. And think about the crazed scientist in a lab doing dark, terrible things. There's never been a significant deployment ever recorded on these. And as far as we know, again, as of last night at about 10:30 at night, nobody has ever weaponized these compounds in a large enough in a large enough amount to be a large concern. And the reason is mustard is stupid easy to make, stupid easy to weaponize, and stupid easy to deploy. There's no such thing as style points when you're creating your chemical weapons to kill other human beings. You just want results. And the mustard itself is just so much easier to make. So that's why it's much more common, much more out there. So from a critical care standpoint, from a hospital provider standpoint, it's really going to be symptom management, respiratory management, aggressive early airway on these patients. We're going to want them decontaminated, which hopefully has been done by the time they get to you. That's going to mean all of their clothes off, all of their jewelry off, and just saturated with water, cleaning agent, and go with that. Any of those blisters that come up, just try to keep them as dry as you can. Try to keep them from bursting, and keep them off of you if you can. That's an added bonus. Nobody likes pustules blowing up around them. I know. But just try your best to support their respiratory, support any signs, symptoms that you see, whether it's blood pressure abnormalities. Keep the blood pressure up. Aggressive with fluids, and airway management on that. Any questions on vesicants? All right. Let me get through a couple more and I will. Yep. Brain chemistry and all that. So we'll talk about blood agents here. Arsine, cyanide, and sodium monofluoroacetate. These are kind of what you got, what take the place in this category. Most everybody's heard from cyanide. That's why I got the picture of the almonds. Cyanide comes from almonds, if you didn't know. Each of those almonds has just a small little trace of them. You get about 10,000, 100,000 almonds together. Maybe you get enough to kill about a person. Which kind of leads to, from the main standpoint of a weaponized system, they both tend to be really impractical. All the blood agents tend to be impractical because there's so much better options. There is a certain amount of pragmatism and practicality around this, and we can spend this time to create VX. We can spend this time to create sarin. If we want, we can do sarin and mustard in the same amount of time it would take us to weaponize cyanide. So nobody's really done it. And from an intentional standpoint, like, hey, we're going to poison this person with cyanide. Outside of mystery books from the turn of the 19th century, cyanide poisoning has never been a particularly aggressive or even largely effective way of killing people. There's better out there. Now, that said, you are likely to see cyanide poisoning, just not in a WMD setting. Cyanide is one of the things of everything that we're going to talk about today. You're going to probably see more cyanide poisonings over your career than anything else here. And the reason is modern plastics, modern synthetic materials off-gas cyanide in copious amounts. So when they are burned, when they combust, cyanide is a byproduct of that. So if you think about structure fires, patients that have been in structure fires in modern buildings, and by modern, I mean anything within the last 100 years, any of the plastics in there is a high likelihood of off-gassing cyanide. One of the things that I'll tell people when they're kind of just coming into this is that anytime you have a patient, we're really good about looking for carbon monoxide poisoning, really aggressive with that. Our monitors maybe have something set up for that. We're aggressive, but we tend to overlook the possibility of cyanide poisoning. And as a general rule, what I would tend to advise folks is that if you're thinking that this patient was exposed to carbon monoxide due to a structure fire, if they're pulling out, they've got some sort of altered mental status or dizzy, assume that they were exposed to cyanide too. Because if you look at the if you look at the symptom list of cyanide, there's just so much there. And again, we've got the rapid heart rate, slow heart rate, hypotension, hypertension. You're going to see all of that, and it's all going to be dose specific. But how many of those overlap, especially the dizziness, the headache, the nausea, the vomiting, the respiratory rate? A lot of those tend to overlap against symptoms that we will typically see in our carbon monoxide patients. So if you wanted to be kind of more analytical about it, not just throw cyanokits at everybody, the folks that you've taken out of a structure fire, you've applied that high flow O2 to try to knock those CO cells out, get the oxygenation back. But after about 5 minutes, if they look worse or they're not getting better, strong indication of cyanide poisoning. Be aggressive with that. So on the left there, you'll see a cyanokit, the hydroxycobalamin. My service that I work for, we carry these on our trucks. I know most critical care probably will. Most hospital-based systems should have access to it. Go ahead and kind of get that on board early while supporting the symptoms. That said, on patients that get the cyanide as a result of a structure fire, you've probably got burns to deal with. You've got airway concerns to deal with. So, as always, airway, breathing, circulation, support those basic functions, but also be looking at fixing that problem as well. Does anybody have any questions about blood agents? Okay. Choking agents. These ones do exactly kind of what they say they're going to do. They're going to cause respiratory compromise in individuals. Phosgene, chlorine gas. Everybody should recognize chlorine. It's an extremely popular agent that's used for public and private, as well as weaponization, and hydrous ammonia. These three here tend to have a lot of uses in industrial type settings. So these ones you're actually more likely to see if an accident occurs. You're going to see these probably moving around. So choking agents do tend to be highly lethal. Phosgene has killed more people than everybody else on the list. Again, clarifying the distinction between casualties, of which mustard has the most, versus actually killing folks. Phosgene, highly lethal. All of these choking agents easily acquired, very prevalent. If you have a swimming pool or know where a swimming pool is, there's going to be chlorine around it. It can be weaponized at home. Hey, these guys you can kind of make and design at your own leisure. So I know Glenn Lookabill was talking about his wife having a cat rescue. So when you think about anhydrous ammonia, cats are very notorious for having very high ammonia contents in their urine. And anybody that's listening to this, if you have a cat and you've ever been a little bit subpar about cleaning out that litter box and you kind of like, okay, I've got to do it. It's the whole house. And you go in there and you lean down and you start to think, man, this is really rough. And you take a couple of scoops out and you're like, I'm okay. I got this. I can make it through. And then after a couple of more scoops, you're like, man, I don't have this. It's time to retreat. That gives you a rough idea. It's not anhydrous ammonia, but it is gassed ammonia that you're inhaling. So you kind of feel that respiratory compromise. You feel that all of your life decisions flashing before your eyes. And you're like, I got to get out of here. And next time I'm not going to let the cat box get this bad. It is common to see accidental exposure with this, especially with pools, industrial pools. We had a case in Durham, North Carolina, probably about 2 years ago. Sorry? Yes? Hello?
Mike.
Moving on. We had a case in Durham, North Carolina a few years ago at local YMCA where they had a chlorine pipe from the basement up into the pool. An issue had happened with the pipe and was actually exposing chlorine gas throughout the facility. And what complicated it was we had about 37 pediatric patients that had been all exposed to the chlorine that were all symptomatic. But they were out on, they had all gotten on a bus and had gone to another site when they were discovered. When the respiratory issues, and they called out for a kid for asthma, and they realized as the crew was there, it's more than just this one patient with asthma. There's actually respiratory symptoms with everything else. And it took us a while to actually tie it back to the chlorine. They did an investigation, found that the pipe was broken, and it had been broken for a while. So when we say accidental exposure is common there, it can happen. It absolutely can. I do have a video here that I want you to watch. It's a very famous training video, kind of amongst the thing, and it's going to be an anhydrous ammonia exposure. And just to give you kind of an idea of what that's going to look like in real time, what's going to happen, kind of how quick it's going to overtake somebody. I apologize for the music. It was appropriate at the time.
To the date, 19 years ago almost.
Mm-hmm. Yeah, just about.
did fire take the time to put on SCBA?
Mm-hmm. So what you're going to see, and I didn't want to talk kind of over it as we're going. What you're going to see fire do here in a moment is getting water. They're going to start throwing water onto the tank, water into the air. The water will neutralize the anhydrous ammonia, kind of make it a little bit more. Personally, I like to see water coming off the fire truck a little bit faster than that. They do them. They're still also really, really close, but they're going to use that water as a barrier to try to get the folks out. That tank is clearly marked. So unfortunately, we learn from mistakes. We whether it's the practice of medicine or operational, the way we do operations, we learn from these cases, and we learn by doing things incorrectly. So if you've ever come through at any point, we talk about scene safety, we talk about that scene size up, we talk about the rule of the thumb whenever you're responding to anything and you see truck on its side with clouds coming out. The idea is to stay away. All of these things we've learned, unfortunately, through trial and error. So this video here, there's actually it's not conclusive. It's one of two things. It's either a real shot from the car and then the trooper died, but there's just as much evidence this was a training video put together by the Illinois State Police to kind of demonstrate the wrong way of handling it. Unfortunately, I've done a bunch of research dives a couple of times. Have been unable to really confirm one way or the other. So, yeah, hopefully it's on the training side. And that officer didn't truly die. It's possible that he did, but
Mayor,
yeah,
have you searched newspaper records for deaths?
have.
Okay. And
There's no record of it.
find nothing publicized.
True. But the date on, if you look at the make of the cars, the design of it, I don't think it was 2000. I think that was an auto set. I think the date was wrong. But if you were watching that video and kind of watching the trooper as he's rolling up on the scene, it starts like many calls do. MVC at this intersection. Are you sure it's this intersection? Because I'm in this intersection. There's no MVC. Well, that's what the caller said. And then driving up, and if you were looking at that and going, man, why are you driving so close to that? Man, don't you see the gas there? If you're looking at all of this and going, I would not have done that, that's because of training. That's because of what we've learned from the past. But the big takeaway with that was how quickly his respiratory drive dropped out, how quickly he collapsed and became incapacitated is definitely that's pretty about accurate of what you could expect with that. All right, speaking of gases, really super common one, riot control gas, CS, non-lethal. It's used in all over the world in police operations. It sucks. It sucks a lot. It's very effective at getting you to not want to be where you are. From treatment standpoint with us, it is non-lethal. It may make you wish that you had made different choices in life. It may make you wish to kind of tap out temporarily. But it by itself is not going to kill you. Really, the big catch is going to be remove these patients from the area, remove any clothes, jewelry, because again, we don't want anything forming or residing on the clothes, on the jewelry that can continue to off gas and maybe kind of make with everything else. Decon is just going to be copious amounts of water. Your typical shower, depending on what your air pressure, what your water pressure is, depending on what your shower, what kind of a shower head you are, and how it's probably you want about double or triple the amount of water that's going to put out. Because it's going to suck. CS, once it gets on you, it takes a while to get off. There's really just no speeding up the process. So just make sure that these patients are deconned with water and then assist them through their suffering, as it were. Yeah, CS is rough. Mostly inhaled. It's okay to be kind of in the air with it. You're going to inhale it. You're going to get it on your eyes. You're going to get it in your mouth. You're not going to see so many symptoms from exposure to skin necessarily. It's going to be that the eye watering. It's going to be that ocular discomfort. It's going to be that respiratory discomfort with it. Psychomimetics. So would you believe that once upon a time, and actually somewhat recently too, the idea of, well, we don't really want to kill these people. We just want to make them stop doing what they're doing. So we're going to deploy fentanyl as an offensive weapon. We're going to deploy LSD as an offensive weapon, and we're going to deploy amphetamines as an offensive weapon in order to control a populace and kind of do whatever we want. Depending on the day I've been having, there are certain attractions to some of that, I can imagine. Psychomimetics through history, it's actually been used quite a bit. So the first recorded occurrence of it was in 184 BC, Hannibal. The whole bit with the elephants and the Russians through the winter used a derivative of a plant as an offensive weapon. And again, he wasn't trying to kill everybody. He was trying to subdue the populace. 1611 in Virginia, by the chief that was Pocahontas' father. He used it amongst a bunch of colonials. It was a variant of a plant, kind of an LSD-ish hallucinogen. Again, you're not trying to kill everybody. You just kind of want them to move away. 1881, France used it. And then in the Cold War, in the 50s, it was a very trendy and popular research subject of between kind of everybody that was kind of locked into that at the time was, again, we don't want to necessarily kill the population, but if we could subdue them enough that they don't fight and they don't want to leave their house and they don't want to kind of do anything other than just lay around, really what they were trying to do was build Facebook back in the 50s, but they kind of went at it from the approach of aerosolized fentanyl. So the next time, if you're giving a patient IN fentanyl for pain control, just think, at some point, somebody spent a lot of time and a lot of money getting me to this point where I could spray this up your nose. So that's kind of the last one of the chemical agents. And if you're looking at the time going, wow, we spent a lot of time on chemical. How long are we going to be here? Everything else from here, it's really actually kind of downhill. The chemicals have a lot of the big hitters and a lot of the ones that required more talking. So in terms of how we're going to treat patients that have chemical agent, something I like to describe as symptomatic whack-a-mole. You're going to see a symptom. We're going to have to move to treat that. But it's all really going to come down to airway, breathing, circulation, same as everything else. Do we have an airway? Are we going to support their respirations? We're going to support their blood pressure. With the exception of your nerve gases and your organophosphates, where we're going to have to come in with the 2-PAM kits and have to come in with the atropine. Beyond that, it's just going to be really a game of dealing with the symptoms as they pop up, so to speak. So does anybody have any questions or anything that they would like to talk about or have kind of a further dive on with the chemical agents? Okay. So before we move on into biological, which is going to be the next category, my watch says it's 10:42 right now. I'm going to take a 10-minute break, get up, walk around. We'll be back at 11. So we'll look forward to seeing and talking with you then. 6.
See who they are. No, Diane is here, Rob is here, Chris May, Chris had a babysitting issue this morning, Danielle, hey Danielle. And Zach is in Spartanburg, South Carolina.
All right.
Zach and Danielle are here for their critical care.
Awesome. We'll pause.
We'll go on for a little bit and then we'll just do introductions after lunch. We're ready to roll.
All right. Share. Let me get my screen back here. No, I'd like you to be smaller. Excellent. Okay. Technology work. All right. So we're now going to move through into the B of CBRN, the biological, and kind of move through that. As I mentioned before the break, it's kind of all downhill from here. The chemical agents take up the bulk of time to talk about. Biological has some heavy hitters in here that you'll probably recognize as we go through with that. So, yeah. All right. So biological agents, they break down into three major classes: the bacterial, viruses, and toxins. And already probably you're looking at that and you're like, I bet you can start expecting what you're going to see on each of the categories. So we'll get into the bacteria first, and right up at the top of the list, there's anthrax. You've been here since the beginning, or you think about WMD, anthrax, very popular, very unique in its placement on the list. Below it is plague, all the variants of the plague. We'll talk a little bit about the variants of the plague beyond that. Brucellosis, glanders, melioidosis, we'll talk about those. Plague is there and it's highlighted, and a couple of them, other ones as we go through this, have that red highlight. The red highlight denotes something that is transferable from person to person. If it doesn't have that, like anthrax, brucellosis, they are not transmittable from patient to patient. You've got to have that main infected source in most all cases where to go. A plague readily spreads between patient to patient. And before we talk about, as we kind of go through this, just randomly putting this slide in there just for whatever reason. We are talking about biotics. And you're going to see penicillin has a tendency to play into all of these. So first up, anthrax, extremely popular as an agent, extremely popular as a fake agent, an agent of coercion, or the pure sense, the psychological sense of that whole terrorist causing terror, putting the fear of everything into people. On the left, you see the letter. That is one of the two letters that was sent to state senators back on 2001. This was the one that was sent to, I believe his name was Hildebrand. And this one actually did have anthrax in it and was one of the precursors, the originators of the whole white powder letter craze, for lack of a better way of putting it. Tons of copycats. Even to this day, the concept of a letter being sent in the mail with a white powder continues to persist, continues to be out there, and causes a huge drain on the safety net and on the public service and public safety net, kind of still on a daily basis. So with anthrax, it's a little bit unique. Kind of one of those the more you know type of things. It's got that 1 to 5 day incubation period, and that's really important, certainly for those of us that are in the hot zone and kind of in that initial wave, understanding that anthrax needs time to incubate before it's going to become symptomatic. So anybody who opens up a letter and says, oh wow, I'm having all of these symptoms and all of these things, it must be anthrax poisoning. Probably not. I don't dispute that you're probably really disconcerted right now, but the anthrax needs time to grow, so that's not what's going to be doing right here. It's also unlikely to have mass casualties, again, just because it does reside in that powder form. It really can't be aerosolized tremendously effectively. It just doesn't have a really good delivery model. So as long as you can keep people out of the room where the anthrax is, you're very unlikely to have a kind of mass casualty situation. Certainly when compared to many of the other items on this list, you wouldn't expect to see handfuls upon handfuls of patients staggering towards you. So once the anthrax does incubate, this is what you can probably see in terms of symptoms in the patient, how it's going to present: fevers, chills, nausea, vomiting, stomach pains, and you can go through that. And the too long don't read on that is flu-like symptoms. Unfortunately, you are going to see this flu-like symptoms block. You're going to see it a lot because that's how people are going to present that have any of these bacteria and a lot of the viruses as well, which makes sense when you think physiologically the body is kind of fighting that off, and things are kind of going with that. In terms of care on what we're going to do with these patients, ABCs and penicillin. The good news about anthrax is if you can identify it, begin treatment with the penicillins within that first kind of 1 to 5 day or even 1 to 2 weeks from exposure, very, very high rate of full recovery, very low overall mortality rate. It's a miserable time for the patients, and certainly the psychological effects can be tremendous. But in terms of actually having its ability to take life, it's not the most effective thing. If untreated and let go past about between 2 to 5 weeks, and it's been incubating that long, if you get past 2 weeks and untreated, then that's when you really start to see the mortality rate rise on the anthrax. That's when it starts to breach 90%. But again, in modern society, those of you that everybody here is working with hospitals or air, probably did some time with ground. What are the odds of somebody who's been potentially exposed sitting for 2 weeks and not at some point going to the hospital to get checked out? You see how it goes with flu season. I've got the flu, I've got the flu, I've got the flu. Systems and ERs get overloaded. It's highly unlikely in America and kind of your more developed countries that you're going to see the case of anthrax persist to the point where it's going to become lethal. Now, that said, identifying the contagion, identifying that it is anthrax, that's going to take a little bit more kind of groundwork. But because of the prevalence of white powder incidents, anthrax is honestly one of the first things that we look for. And when we're going in there to try to see what we've got to work with, what's causing what was in the letter, we have tools. We can figure out if it's anthrax within about 2 minutes. So it's certainly something we look for pretty much immediately, which all the copycats have taught us. And yeah, still to this day, we see white powder incidents all the time. We in Durham, it wasn't widely publicized, but we were chasing a white powder person throughout the city for most of the summer last year. It was great times. Eventually found him and was able to capture him. But there was about 4 or 5 different letters sent at different times to different places. And I am very certain that my story is not unique and that's probably perpetrated everywhere. So that's anthrax. It's really not as scary of anything on the list. If you tell me, that there's an anthrax in that building, because it's airborne, and I'm not going to be that really worried about it. Easy to defeat on all ends. A little bit scarier is the plague. And you see that that cute little plague rat there staring back. I would just like to say, if you haven't been keeping up on the research, rats have been 100% totally, completely cleared and vindicated from their role in the 1500s, the Great Plague. 50 to 60% of the world's population. The rats had nothing to do with it. It was the humans with fleas, which is no less disgusting, but it wasn't the rats. So the concept of plague rats, do my little bit for kind of rat freedom here. So anyway, moving back to bacteria and the plague, you've got 3 major categories. You've got bubonic, septicemic, and pneumonic. Again, depending on how it's going to affect the body, it's the same chain. Plague itself, and then how it enters the body is where it gets its subclass. But if you're thinking about bubonic plague or pneumonic plague, it's the same thing. It's just how those symptoms manifest, but it's the same root. They can be seen as a progression independently or altogether. In other words, you might have a patient that has bubonic and pneumonic, but not the septicemic. You might see a patient that's just got the septicemic. You also might see somebody that's got all 3. The good news about the plague is that it is obsolete in modern society. Some of the biggest things that we have seen is between sewers, treated water, a lot of these bacteria-related illnesses and vectors have just gone away and aren't effective anymore. They can spread from host to host by coughing, which does make it particularly scary in terms of if you do have that patient zero, it is possible for that patient to kind of infect the bubble around him, and they tell 2 friends and they cough on 2 friends. That said, even if untreated, mortality rate for the plague is 50%. Clearly, we have had a really large sample size and studied the plague in the past. We used kind of all of humanity as a sample size, so we're really confident in that 50% untreated mortality rate. But with treatment, it's not that bad at all. So when you do have the plague, again, you're going to get if you have the bubonic variety, the fever, the chills, the tender lymph nodes. Oftentimes, it will then progress to septicemia. So septicemia is everything from the bubonic list in addition to the blackened tissue. You're going to see that necrotic, kind of frostbitten appearance to the tissue. It's not just going to be isolated to fingertips and toes. You're going to see splotches on the arm. It can be completely random, but if you're gonna see that in addition to everything else. What's interesting about bubonic and septicemia is that those 2 varieties of the plague are not contagious. It's only when it develops to the pneumonic, which is when you get that pneumonia, you get that frothy, bloody sputum, you get that pleural effusion kind of going on, spitting up. That's when it becomes contagious, because that's when your patient's going to cough. That's when it's going to get out there. So from a treatment standpoint on these patients, it's really going to be just supporting the ABCs and giving them penicillin. Because these are bacteria, penicillin is hugely effective on this. Amoxicillin is good. Your floxins, your Cipros they theoretically could work, but they've never been tried. Whereas there's a host of evidence about the penicillins, the amoxicillins that are effective with these particular categories. And those are really the 2 big ones: plague, anthrax. You think about those; they have a heavy psychological impact, which is the point when you're deploying them as a weapon, or when you're trying to get others to kind of see your viewpoint, is to using that as that. But in terms of symptomology, in terms of patient mortality, and when you get to the nuts and bolts of what it's really going to do to your patients, I don't want to say it's going to be fine, but they're really ineffective and easily managed at all levels. We talk about the other ones very briefly. The brucellosis, glanders, melioidosis. These tend to be very regional. They tend to be very located in certain areas. Brucellosis, Mediterranean, around the Mediterranean Sea, you're going to see that. Glanders tends to be horses, livestock related, and then the people that care for those livestock are the ones that you're going to see that potentially could have that. There haven't been any confirmed cases since 1940. With that, still other parts of the world, underdeveloped sections of the world, that you might see some cases. But in terms of it being a valid threat, something that we need to kind of have on our radar, not really. Amyloidosis, you're going to get that from contaminated water and soil. There's a small little section of northern Australia and southern New Zealand that you're going to see that, but the only way to get that is to actually drink the water from those contaminated wells or ingest the soil in those areas. It's not a transmittable disease. And over here, where we have modern water, we have chlorine tablets, water purification devices, as well as sewers. You're really not going to see it. Treatment for this, and you'll see the flu-like symptoms hanging out there in the back, because again, patients with these ones are just going to present generally with flu-like symptoms, and we're going to give them penicillin. And between all that, you're going to be able to manage any of the bacteria on this particular list and on any of the lists. And that's going to close up the bacterial section. We're about to move on to the viruses. Does anybody have any questions about the bacteria? Okay. So now we're talking about the viruses, and now we get into the really scary stuff. I can handle a lot of the things and the chemical stuff. I understand how it works. It's easy to kind of predict how it's going to move when you're modeling how a disease gets transmitted or how a vector gets transmitted. Having that root source of the weapon, this is where the cloud started. I'll work the math all day for how it'll drift across wherever, who could walk through the clouds, who could walk. Viruses, though, these are scary because these ones are going to be the ones that are going to transmit from person to person in a lot of cases. And these are also going to be really random, where you've got your patient 0 and who they interact with and their friends. So the big ones on this list: smallpox, Ebola, and Marburg. Smallpox, it's rough. It was eradicated in 1977. There are no naturally occurring traces in existence. Now, when we say stuff like that, we'll say, well, there's no naturally occurring traces. There are a large number of research labs with certain security clearances and certain purposes that do have active smallpox, but it's not out in the wild. It's not something that you'd be able to catch. It would take a catastrophic breach of a number of large layers of security before they ever kind of got released to the wild. But what you're seeing there is a picture that was taken in about 1911, 1910, 1911. And you've got the patient on the right wasn't vaccinated for smallpox, and the patient on the left was vaccinated for smallpox, or was not. You can tell the difference. Smallpox was eradicated in 1977, declared officially dead and gone by the CDC and various other regulatory bodies due to vaccinations. I'm just going to hang that right there and leave it. But smallpox is gone out in the wild. In terms of its effectiveness as a immediate killer, it never really had those capabilities. It made life very difficult. It did have the potential to downstream in somebody's lifespan, have very significant impacts, even lethal impacts. But in terms of something that's you're immediately exposed to it, you're going to die within the next 72 hours. It simply doesn't have that. While the vaccination does exist, it's worth mentioning the side effects from the vaccination and the risk profile of the vaccination are such that it's not recommended to be given out kind of regularly. So unless you're working around, have a very good reason to be vaccinated against smallpox, it's absolutely not recommended to be given out to that. So let's move on to everybody's favorite, mine and yours, Ebola. Obviously, I'm assuming that everybody that's watching this lecture and kind of looking to increase their scope of what they can do and push forward in their career has been doing this for a while and probably remembers the great Ebola scare of 3 or 4 years ago. And how the entire world flipped on its head and 911 call centers everywhere were flooded with cases of Ebola. So here's some of the facts about Ebola. Number one, similar transmission as HIV, which means that you've got to have contact. Somebody who has Ebola is symptomatic with Ebola. You have to come in contact with any of their bodily fluids, direct contact with their bodily fluids, whether it's saliva, whether it's blood, whether it's urine, whether it's feces, whether it's semen. You've got to have that direct contact with that. And if you don't have direct contact with that, you're going to be perfectly fine. Only patients that are symptomatic with Ebola are going to be the ones that are able to transmit the disease. Just because you may have that viral load on board, just because it may be working its way to starting to take over the system, you can't pass it on until it becomes symptomatic. And average incubation of Ebola is 8 to 10 days. So again, anybody who is immediately exposed to it, you're still not going to see anything from 8 to 10 days, a week, to close to 2 weeks. And that's where it gets really scary when you're trying to control or predict how this disease, how these diseases and this virus is moving through the populace, what's at risk, what's not, because you're going to think you're fine up until a week and a half later where you're not fine, and you can move anywhere. I know the system that I worked in, we had a number of Ebola cases during that kind of little hotspot, and it was no fun. Your symptoms, again, there's the flu-like symptoms box. With the added, you're going to have that unexplainable hemorrhage, and that's going to be typically through your skin, through your nose, through your mouth, anywhere where tissue is kind of gets weak and can broken down. They're just going to start bleeding, and it's not going to be a pretty kind of bleed. It's going to be unexplainable. Like, I don't know why I just started bleeding out of my arm, but here we are. And that's when you're seeing your patients. They're the most symptomatic. And if it does happen to evolve to that point, then the mortality rate of the patient that's gotten that far is really, really high. In truth, there is no effective treatment. Penicillin will not work on it. It's really just supportive care, maintain that hemodynamic stability, maintain the respiratory function of these patients, and let their own, it has to be the immune system of the patient itself, which overcomes it. Clearly, we've done a lot of research on this. So I know we're trying actively to try to figure out ways of speeding that along and working it, but nothing, don't have anything effective yet, just theoreticals. Marsburg, hemorrhagic fever, primarily centralized in Uganda. But again, this is one of those ones that because it incubates and because it kind of moves on from different places, this is the one that we look at and we go, hey, this is something we might be able to deal with. And I do have the guilty fruit back there because this particular disease we have directly linked to coming from fruit bats. So unlike his wingless friends who have been demonized throughout history, unfortunately, this sly-looking guy is actually really guilty. So if every time you have somebody that just kind of going to have those flu-like symptoms, they're also going to have a rash somewhere on the trunk, whether it's the back, whether it's the chest, whether it's the abdomen, and it's going to be this kind of weird, out-of-place rash that they can't explain. No other signs or symptoms suggestive of any sort of anaphylactic reaction or allergic reaction. It's that rash is kind of the hallmark of this hemorrhagic fever. Hemorrhagic because they're going to start bleeding out through the tissues. They're going to start excreting blood in various ways, along with the flu-like symptoms. With Marsburg specifically, asking about patients' travel, identifying anybody who's been out of the country. If they've been anywhere near Uganda, then it's definitely something to have very high on your differential list. But very similar to Ebola, this is something that the patient's immune system is going to have to work out on their own. The best thing that we're going to be able to do for them is just provide symptomatic support, make sure they're maintaining blood pressure, make sure they're maintaining blood levels, clotting factor, oxygenation, breathe for them if necessary. But really, there's nothing we can do but to help them kind of ride through it. All right, now we're going to talk about toxins, which we're getting to the end of the kind of the biological list here. You've got aberrin, colchicine, ricin, strychnine, and tetrodotoxin. And aberrin and colchicine are given that kind of gold highlight because they are actively used. They have medical purposes in the treatment of certain medical conditions, and they are utilized for medicine. So not particularly, not weaponized, not something we're concerned about it being used in the populace. In fact, you can get prescriptions for the same, and perhaps in your career you've seen it. I've seen colchicine a few times myself, but that does leave ricin, strychnine, and tetrodotoxin. So this stuff, these are all really scary. These are all things that have a very high lethality profile, low amount of exposure, and they are going to be very hard to manage. There's no cure for any of them. There's nothing but symptomatic support that we can offer. and they're all occurring naturally in the environment and can be fabricated and can be acquired relatively easy, of which we've got ricin, which comes from the castor bean, and you can buy bags upon bags of castor beans very easily and make your own ricin if you were so inclined. It is highly lethal. It can be aerosolized, but because of how quickly it evaporates, it's impractical for purposes of mass murder. It is, however, practical for assassinations. And if you look in the lower right, there was a case in the Ukraine back in the 70s where the Russian KGB did actually utilize that umbrella, which, like something out of a spy movie, does in fact have an injection system in it, which delivered a pellet full of ricin into this minister and did in fact kill him. So there's your the kind of spy history for it. But ricin, if very low dose, does have the potential to kill somebody pretty quickly. And historically has been very easy to make. But it's much more suited for individual types of exposures and assassinations than looking kind of mass murder type. And we'll go.
Whenever I looked up ricin, the information I saw, it said that most people, when they're trying to develop the ricin, end up killing themselves because it's so lethal and they're careless with it. So they kind of self-contain themselves.
Yeah, that's a wonderful way of putting it. Self-contained risk. You know, I think everything on this list, there's probably people have tried to create. When we get to talk about explosives, there's a lot of morbidly fun and interesting stories of ill-meaning individuals who have self-corrected on their own. But yeah, ricin, because it is so toxic and you're trying to crush the castor bean and you're trying to get that little soil, if you don't have like laboratory perfect training and attention to PPE, yeah, it's absolutely can wipe you out with very little effort. Definitely. Strychnine. This one here is still commonly used as a pesticide. It might tickle the edges of your memory looking at thinking about it. It's a favorite of farmers anywhere where you need to keep groundhog populations or rats or anything which could potentially interfere with crops. Strychnine is still very popular to this day. It has been around for a while. There are multiple cases of it being cut into LSD. Never being the person to, I don't know. I have nothing on that. You know, you hear the joke about, you know, was your stuff cut with rat poison? That's exactly what they're talking about. Was your cocaine, was your LSD cut with strychnine? Yeah, man, it's the buzz, right? Literally, because if exposed to strychnine, it is going to cause persistent spasms, uncontrollable. They might not necessarily be global. They might be more focal in nature, whether it's the arm, a leg. But these are treatable through benzodiazepines. Just get them on board early and support them with that way. But in terms of being used as a weapon of mass destruction, the only thing I could see, the big concern would be if those individuals that have access to a plane with a spraying system on it, it wouldn't take much for somebody to kind of go rogue and introduce this in some way to that, depending on the form that they had as a pesticide, and make a whole bunch of people sick. But you could just manage that pretty easily, and I think that would be a very easy one to kind of look at, contain, and work on neutralizing. But strychnine, huge history of it. Again, you're going to see that a lot in turn of the century, 1900s stuff. At one point, they said they thought it would cure what ails you, and it was marketed as a miracle cure for a whole bunch of stuff. And as long as life is on the list of things you're trying to cure, yeah, it probably did work. And last but not least, one of my favorites on the list, tetrodotoxin. It is the ubiquitous pufferfish poison. There's Simpsons episodes of it and a whole bunch of different cartoons and things out there and comics about the idea of the forbidden sea fruit, eating pufferfish, and you're good as long as it's prepared by somebody who specifically knows how to avoid liver. Again, this is not something you're going to see as a mass murdering type of thing. However, it is very effective at doing its job of killing individuals. So easiest way to avoid this, leave the pufferfish alone. Don't eat them. And if somebody offers you prepared pufferfish, just say no. And that's going to be the end of kind of the biological and toxin segment. Does anybody have any questions on that before we move on? Sweet. So I mentioned at the beginning of this, I was going to be combining radioactive and nuclear together. And I'm going to be. Nuclear in this context is really just referring to the force of the explosion. So it has a lot of overlap with the explosion part of CBRN. It has a lot of overlap there. Radioactive, dealing with the fallout, dealing with the radiation exposure, it is something that you're going to see, but they're going to go hand in hand. If you have that kind of nuclear explosion, it's going to create the radioactive, and the explosion is going to be handled like you would handle any other explosion. It's the radioactivity and the fallout to that. So one thing I want to do before we kind of dive into this radioactive a little bit is I do want to do my best to kind of dispel some of the myths and some of the ways that people kind of perceive or can perceive what a nuclear plant exploding looks like, or what a nuclear explosion can look like. This is they'll talk about it as they go. Hopefully. So I would love to be able to click that button and it works. You don't see me madly clicking the button, but I am.
We've had a little problem with video displaying through the.
Well, that's awesome. There we go.
There you go.
I'll just move to the next screen. So wanted to kind of to show you that, to show you kind of what it looks like when a nuclear power plant does explode, which is far different than the weaponized nuclear energy. There's no mushroom cloud. There's no kind of giant devastation going around for miles and miles around. Terrible thing, certainly. And as you can see, hugely damaging to the actual facility itself. But the likelihood of your classic mushroom cloud station going off with modern construction techniques is not even a theoretical concern. It's more of something that you can philosophically say, well, if this and this happened, realistically, very, very unlikely too. So I know I let the whole thing play because that expert was talking about kind of how the explosion wasn't necessarily the core, and how that kind of worked out. With Fukushima, all 4 cores were involved. All 4 of them did breach, but they were able to pretty effectively get that shut down and get that under control. Interestingly enough, there were 0 deaths due to radiation or the explosion from the incident. So you look at all of that. They knew it was a lost cause, and they were already in the process of evacuating when that tsunami hit, overwhelmed the systems. There were 2 fatalities that did get attributed to the natural disaster part of it. The tsunami hit. But in terms of the actual explosion and the fallout of that, there were actually 0 deaths due to radiation or the explosion. There were overall over 2,000 deaths, however, related to the disaster itself. But all of those were classified as disaster-related deaths, specifically due to the evacuation. And where you're getting those numbers, where you're getting those deaths, are from your elderly, nursing-dependent patients that require complex medical care ongoing, that because Fukushima Prefecture and all that were evacuated because of the fear of radiation, because of the evacuation, they were not able to maintain that level of care. They were not able to kind of get that constant access to medications and things they need. And that's where the deaths came from, the complications as a result of that. Additionally, the shelter conditions, that also, if you were immunocompromised or immunosuppressed for any reason, you were going to be at a much greater risk potentially for illness. And overall, you did see, 2,129 deaths related to the evacuation. But none of them were radiation-related deaths, and none of them were explosion-related deaths. The after-action report on this, they did make the comment that there was so much of fear of the radiation poisoning and the potential impacts on the environment that they actually held the evacuation order for what they considered to be too long and unnecessary, because everybody was thinking, kind of a Chernobyl type of situation where you're having that release of contaminant into the environment. But with the way that modern systems work and modern reactors go, it was never a realistic concern. So they developed policy based on emotion rather than science. And unfortunately, that contributed to a good share of these deaths that were in there. So when we're talking radioactive, radiological, or nuclear, again, it's not really going to look like anything Hollywood ready. Michael Bay couldn't really do it. It's going to be very subtle. It's going to be much more of a chess match than a checkers match as you're going through. It's in terms of your mortalities and your patient profiles and where you're really going to be worrying about folks are going to be a long-term issue. This is going to be something that's going to take place over weeks and months and possibly even years, dependent on the level of exposure. It is theoretically possible to die immediately because of a radiation exposure to radiation or a leak, the radiation leak. But it's extremely unusual, extremely rare, and much more likely that you're going to have that multi-system trauma because of the explosion, that's what's going to cause the death of the patient as opposed to the radioactivity. Immediate care of these patients is going to be aimed at supporting vital signs. There's going to be nausea, there's going to be vomiting, there's going to be pain involved. What we want to do is just try to keep them as comfortable as possible. It is a good idea to presume that any bodily fluids that come from this patient, whether it's secretions, vomitus, feces, are radioactive, and adopt that universal PPE kind of approach to it with eye protection, and kind of roll with that. Reality is, again, it's more of a theoretical concern. It's more of a minimal one, but it is something we can measure, and it is something we can look at and go, okay, I can see realistically how this could happen. So let's just take the precautions ahead of time. In terms of how radiation works, there's 3 classes. I don't have a slide from that. I was actually planning on using the whiteboard to kind of augment that. You've got 3 classes of radiation: alpha, beta, X-ray, and depending on how you're exposed to them, basically what you wear to work on a regular basis is more than enough to deflect away any alpha rays you might get. Beta, that's when you're going to need a wall of some sort, whether it's concrete, whether it's lead, whether it's got to be substantial. That's going to protect you from that. And then X-ray will go through anything, but it's very, very, very short in terms of how much of it's coming out. So in terms of a hospital provider, even a hop zone operator like myself, X-ray, we're not getting that close to the core. That's a robot's job. So we're not really worried about the X-ray. So take comfort knowing that what you're going to see from these patients, and especially the patients themselves, even if they are radioactive, it's going to be at the alpha level because they're not a source themselves. What you're wearing normally and what you would normally don for PPE will be more than sufficient to keep you safe from that. Any questions on radioactive or nuclear? All right. And finally, the E in CBRN, we've almost worked our way to the end of the list, and now we're at the explosive section, talking about explosions and explosive stuff. And this is going to be a really kind of a good news, bad news type of thing. The good news is by the time that we're responding, or by the time we're making patient contact or transporting patients, whether they're by critical care ambulance, by helicopter, by ground ambulance, the incident is over. Obviously, the patient is still in jeopardy, likely a lot of gruesome injuries, a lot of multi-system, a lot of different problems we do expect to see in these patients. But unlike everything else on the list, this isn't going to be a persistent threat. It's already happened. We're just now we're being reactive. We're just dealing with the fallout. But it's not like everything else here where there's still that potential for secondary infection or secondary contamination. With explosion, hey, it's over. And it's all trauma. So there's not a lot of, we don't need weird and exotic medicines. We don't need specific antidotes. We just need to do our job and help support trauma surgery and the trauma process. Explosives, stupid easy to make. If you look at the Oklahoma City case, where the government building was destroyed by essentially a Ryder truck, and somebody sufficiently motivated. It is extremely easy. The device and how he used the explosive that he used to take down that building is very easily acquired. It's out there. This isn't hard. This is the stuff that a lot of research goes into because it's so easy to make an improvised explosive device. The components are so prevalent that this is the scary one in terms of that massive number of injuries. And if you're looking at, hey, I'd like to kill a populace, or I'd like to instill terror in a populace, or support a plan, or push a government one way or the other, using explosives is a efficient way to do it, simply because it's so much easier to make and so much easier to deploy than everything else on this list. But you're likely to see that, whether intentional or unintentional, for that. So let's talk just briefly about some WMD response principles. From a critical care standpoint and from a helicopter standpoint or a hospital-based EMS standpoint, it's unlikely, it's unlikely that you're going to be in that initial phase. But when we're trying to set up an incident, this is kind of what we're looking to set up. You'll see the incident in the corner or in the middle, and that's our hot zone. Remember all of that initial training, hot, warm, cold zone. Pretty much everybody, if you're taking this class, highly likelihood you're going to be a cold zone or out of the cold zone operator, simply working on help and care for the patients as we're bringing them out and getting them where they need to be. Couple of interesting things about this. The patients are going to be decontaminated by the time that you get there. That's not something that you need to worry about. That will already be taken care of as part of the team. And you can see the decontamination corridor in the warm zone as patients are coming from that hot zone coming through that. So just 4 basic, I just kind of threw up 4 rules that if you take nothing else out of this today, if those 4, when you're dealing with a WMD exposure or potential, don't be a casualty, protect yourself. Make sure you're not freelancing. Go where you're supposed to go. Be predictable. If somebody assigns you to stand over here with your unit, please just stay over there with your unit. Even if it doesn't see, if you're like, I could help doing so much more. I could do this. I could do that. Please stay where you get put. Be predictable with that. Be patient. These scenes tend to be a lot like chess matches. Huge, small little bursts of activity. A lot of thought, a lot of planning, a lot of analysis. Another small burst of activity, a lot of thought, a lot of analysis. Just kind of bear with everything. But these situations are managed and risk is minimized through thinking, analyzing, planning, and applying excellent, good principles to it. And overall, be methodical. When you're assessing your patients, you're coming out, it's not likely, we probably don't know what necessarily agent has been used. So fall back to initial training, do that assessment, support the airway, the breathing, and their circulation. And then just kind of look for the signs, look for the symptoms. And when you've got your PPE on, whether you're putting it on or taking it off, follow the instructions, follow your protocols on that. They're there for a reason with that. And overall, this is kind of, what's the word I'm looking for? Sums up a lot of those principles. The patient's going to be decontaminated by individuals on the decon line. Make sure you've got respiratory protection. There's no telling what agent might be in play. Most of them do have the potential for airborne contamination. Be comfortable in PPE. Folks that I work with, folks that come through, you're shown how to maybe put PPE on one time in a PowerPoint, sometime in an initial class, and you know it sits there in that box underneath the bench seat or on the side of a truck. That's where all this stuff lives. But if you've never put it on and you've never learned how to get comfortable using it, how it changes how you have to approach patient care, how you have whether it's bagging, starting an IV, starting an IO, programming a pump. If you've never done that in PPE beyond just the gloves, but the Tyvek suit and with the mask and how hot it is and how your peripheral vision gets shot, my recommendation is try practicing with that stuff on there so you're comfortable, because when somebody hands you that patient with Ebola and now you've got to deal with the stress of that patient, it's kind of not the best time to be figuring out, hey, also, I'm hot and claustrophobic. This sucks. Don't expect a really decent patient handoff, especially from the decon line. because a lot of times there's just a ton of patients coming through. There's not really much of an assessment being done on anybody. They're either conscious or unconscious, with a pulse, without a pulse, breathing or not breathing. That might be the best you're going to get. Again, WMD, mass casualty situation, the rule set's a little bit different than it would normally be. So just expect to have to do the whole assessment from scratch, and try not to get upset if you're just kind of throwing somebody and, well, hopefully gingerly placed somebody and said, hey, this person needs to go from here. Information from the scene will be unreliable and chaotic. The concept of the fog of war is definitely going to be, if you're not familiar with it, the idea that the information you're going to get is conflicting. It was this, it was that, it was this other thing. You're going to know an incident happened. It's going to be likely, we don't know yet what exactly the whole, everything that did happen. But again, just kind of work your way through, like, hey, I've got a patient that's got burns to 60 to 70% of his body with a whole bunch of trauma. So I'm just going to deal with that. And we can talk about how we got to this point later. Because really, when you get down to it, you've got a patient with massive burns and penetrating trauma. That's what we need to deal with. Don't get hung up on the details at that point in time. And play to the worst case scenario from a medical perspective. Always be thinking, what's the worst that could be? And again, this is exactly how we do differential. This is how we kind of manage our patients from the best of times. But if you see that there's a whole bunch of patients presenting with a whole bunch of different symptomologies and things like that, there's kind of like, hey, it could be this, it could be that, it could be VX, it could be a sarin gas exposure. Likely not true, absolutely. But it's certainly theoretically possible. So like we do all the time, and you're always told to kind of work that differential from what can kill them first. Certainly it will help with WMD, especially when you get your management of, all right, I'm going to take care of the airway. I'm going to work on breathing and I'll work on circulation. And kind of roll from there. So that is going to bring us up kind of to the last part. And are there any questions? All right. Is there anybody still there?
Well, you ready?
Zach's here.
Okay.
We're here.
Chris is
So when we did when I did my initial slide, and for those of you that
I'm still.
Martha.
I'm still.
Got you.
when we did the initial slide, and I had that kind of vanity up there. When we had that initial slide up there, I kind of I'll come back to that. But recommendations. So there's an app that you can get on your cell phone, on the Apple Store or on the Google Play Store, the Wiser app, W-I-S-E-R. My recommendation is anybody who's involved in medicine, especially that possibly could go out in the field, make sure that you have it. Make sure that you have it on your phone. It is a wonderful source of everything we just talked about. Goes much deeper in depth. If you want to know the chemical composition of anthrax, it's got your hookup on that. It's a very responsive program. It's constantly updated. It sits offline on your phone, so connectivity isn't an issue. And it is the key. It is the keys to the kingdom for the management of anything weird, exotic, or mass death killing that you're going to come across. Check the dates on your Duodot Mark II kits, whether they are in your truck, whether they're on your helicopter, whether they're in your, wherever they happen to be. Make sure you're looking at those, and if they are expired, get with your supplier, see about getting new of them. Also, if you're issued a respiratory canister, you got the gas mask, make sure you're checking the date on that. Make sure you're aware of that, because you don't want to necessarily end up in a bad scene and pull that canister out hoping it's going to protect you against the badness, to realize that it expired 3 years ago. And then check the dates on your PPE in general, especially if you've got those Tyvek suits or those bags. And I appreciate how they can kind of get stuffed underneath the body bags in weird and obscure containers, but make sure that they're intact. Make sure that they are still good to go. My contact information is there. Please don't judge me for the email address. I was very young and stupid at the time, and somebody just handed me an Android phone and said, hey, you need an email address now. But feel free to email me, call me, text me with any questions that you might have. I'll be happy to help. Always happy to kind of do what I can to help everything like that. And here's a list of the references. These are where I got and double checked all of the information I've got. And you will see as you kind of just scan through that how many of them are government related. Yes, I will admit I did go to Wikipedia because when I saw that psychochemical and people weaponizing fentanyl, I'm like, no. I really had to take a double look at that. But the CDC runs a ton of stuff and is very happy to disseminate information. OSHA, things with that as well, DHS, Department of Homeland Security, the FBI. So you can check through that. So before I leave you, I know we had a number of individuals that came through. So what I want to do, end it.
Hey, what happened? We lost you.
Yeah, I lost him too.
He probably hit the wrong button, maybe. I don't know. Somehow I'm the host.
Where's my peanuts and crackers?
Martha,
Yes.
Max thought he disconnected Zoom, but since everybody is still here, obviously he did something, but he's not on it, but it didn't shut it down. But anyway, we're breaking for lunch. It's 12, so I'll be back at 1:30, guys.
1:30.
12:30, you said?
1:30.
1:30.
We could do one. Yeah. We'll have to go in two different cars because I got an errand to run. So you just follow me to lunch and just go to your little Zoom icon on the bottom tool tray there. I think you're still on. You're just not sharing that screen. Are y'all seeing his initial?
No.
Okay. What are you seeing, Rob?
Well, I have me as a host,
Okay.
and then it's got you, Martha, Chris, D.
Diane.
Sparrow, and Zach.
Okay. All right. Well, we'll figure out how to if you'll just pause recording, if you're the host, if you'll
Okay.
pause recording, then Max wants to start back at 1. So I'll let you pass host back to him when he starts.
All right. Hello, everybody. We're going to continue on here. Next topic to talk about after the wild world of WMD and ways to kill you is to come back and we're going to talk about communication and documentation and the importance of kind of both of those to what we do and a couple of tips on how we can do it better, but also just to kind of underscore how things work. And as we go through this, we'll talk through some communication principles. How continuity of care can be affected by communication, documentation, principles of effective documentation, some reasoning why it's really important as part of that continuity of care on that. So first up, we'll talk about communication, and this is one of those things, it's kind of a tricky subject to broach for a lot of people because let's face it, we talk all the time. We communicate on a daily basis, whether it's to our friends, our family, our loved ones, our patients. But we don't really think about how we do it because it's just something that we intrinsically handle on a regular day-to-day basis that the efficiency of our communication, are we getting the message across, are we getting it across effectively, unless you're purposely going out of your way to think about it, is really not something that you look at and explore. And of course, for healthcare, what we're doing a lot of times in a very critical environment, a lot of times we need something done in a very timely fashion or a very specific fashion. Communication becomes a huge thing for us to ensure, are we communicating properly, both with our team, our partners, our co-providers, but also when we're talking to the hospitals or the doctors and the physicians and the teams that are taking these patients from us. We want to make sure, ideally, that we're communicating as effectively as possible in order to ensure the best possible continuation of care for that patient. And ultimately, it does affect overall patient care, how that kind of goes about it. One of the main ways that a lot of research and studies and kind of conceptualizing has come through is the concept of that closed loop communication, which you can't really underscore the importance enough. The closed loop communication is made for people who work in situations where there's high risk, high stress, low amount of time to deal with it, and where error in communication could lead to a potentially negative outcome for the team or for the patient. At its simplest core, all closed loop communication essentially is going to come out to is making eye contact with your receiver, or making sure that the receiver has your attention. You're going to give them the message, and then the receiver is going to copy back the message. And it could be something as simple as, I need you to go get me a bag valve mask and an OPA. And the receiver saying, okay, I'll be back with the bag valve mask and an OPA. Something to that nature. Or, if we want to kind of keep riffing on medications and WMD, I need you to go grab me a milligram of atropine. Okay, here's your atropine. Just keeping that closed loop communication so that I know that not only me as somebody who's saying the message, that it's getting across, but also that the message was received. And you've built in, by doing that, you do have kind of a check and a balance. You have that integrated double check. I guess that really is the best way to say that. But you do have that integrated QA safety thing, that if you hear something come back, if you hear them say something, it's like, wait, that's not what I meant. Or if you said something, it's like, now that I'm thinking about it, maybe I don't want to give this extremely tachycardic patient atropine. Maybe that would be a bad idea. So closed loop communication, it's used very frequently, very consistently across a number of different disciplines. A lot of this stuff we look at the FAA, we look at pilots, whether it's civilian or commercial or military, specifically on the commercial side, because if an error is made, it's obviously going to impact a lot of lives. And of course, they've spent a lot of time studying and analyzing issues that have come up. And closed loop communication as a concept is something that we need to be integrating, certainly in as many situations as we can, just to make sure that the lights are on and somebody's receiving. So we'll talk a bit about radio etiquette. A lot of our time is spent, obviously, with patients and with teams, but some of the more high risk or places where balls can get dropped and wires can get crossed is a lot of times communicating with on the radio, whether it's with dispatch, whether it's the receiving hospital, whether it's with another unit. A lot of times we don't provide enough guidance for how to communicate on the radio. We'll just hand somebody a radio and say, okay, this is how you communicate. This is how you get contact with the base hospital. Go for it. And there's a couple of rules that are there and should be observed, but we're not really good as a profession about kind of coaching people through or mentoring through. And the first and the foremost is, don't just pick the radio up and click the button and start talking. Make sure you're not walking over somebody. Make sure that channel is clear. Apologies. Make sure that the available, whoever your receiver is not currently talking to somebody, is not trying to not trying to get information or relay information, or who knows what they could be doing, whether it's trying to get orders. Just make sure the channel is clear. Call your receiving hospital, call the other unit. There's many different ways of doing it. A really good one that does work for a lot of different agencies in a lot of situations is the "Hey you, it's me" approach, by which we'll be saying, hospital emergency room, this is Medic 1. And then you wait for that confirmation from the other side, but you don't just key the radio and start talking. You want to make sure that you've made that contact, that initial, okay, I'm here, I'm listening, I'm ready for what you want to say. Clear and concise. When you are getting into giving your information, please be as concise as possible, be as clear as possible. I think everybody has a story of that person that gets on the radio and wants to tell their life story, or a bunch of not necessarily useless, but certainly not applicable and not priority notes to make. So please just make sure you're being clear, be concise, know what you're going to say. Indicate the end of the message. When you're done, put some sort of feedback in there, put something in there so that you have the ability for the person on the other end to know, okay, it's their turn to talk. Because especially with radios and the trunking systems, only one person can talk at a time. So you want to make sure that you kind of throw in, do you have any further instructions? Do you have any further questions? Something in there that's a definitive end. Then you're going to wait for those instructions and acknowledgement. And whether you're the one on the receiving end or the giving end, just say nothing further. We'll see you in 10 minutes. We'll see you in 5 minutes. Or maybe they have a question. Go ahead with that. Wait for the question. And then acknowledge that you got the message. And finally, call clear on the radio. It's a silly little thing, but if we go back to number 1 on this little list here, if you're waiting for whoever you're talking to stop talking so that you can come in, it's courtesy, but it's also efficient to be like, Medic 1, no further, we're clear. That way, if there's somebody sitting there waiting to key up, they know that I'm done talking, they can start. And these are things that for a lot of people, maybe if you just kind of figure out on your own, trial and error, but it really makes a big difference. And the higher the acuity of the patient, the higher the importance of the information that we're trying to convey, the more important it gets to get this right. And if we're not practicing or teaching or coaching or mentoring and proper techniques in the beginning, we can't really complain all that much when issues and errors happen. One of the things that we do come across with, especially when you're contacting base hospitals, whether it's the charge nurse in the emergency room or the dispatch, but specifically in the charge nurse, whether you're bringing a patient in by flight or you're bringing them in by mobile transport, the person that's got the radio, and a lot of times your charge nurse has a lot going on. They've got pagers, they've got doctors, they've got other EMS that might be there that are waiting for an assignment. They've just got so many things they're trying to do. They're holding conversations that we need to make sure that we are using as much of that intention as we can, but that we're also making sure that we're keeping our message as clear and concise and doing what we can to get that attention span, keep it, and clear out so that that person has the ability to go and continue doing what they're doing. An example with this that I'll kind of demonstrate here as we go. So if I was to call in, if I was calling in a report and you're receiving my report and it would go something like this, let me know what you think about it, if it's a good idea, if it's a bad idea, or how much of your attention span I actually kind of kept. Medic 1 to hospital. We're inbound, non-emergency traffic. We've got about a 15, 16-minute ETA. We're bringing you a patient that's got some kind of orange stuff going on, kind of seeping out over the sides. There's these little green discs everywhere, kind of with that orange seepy stuff. We do have some cheese. There's some cheese around as well. That's just kind of hit or miss in there. There's these 3 disc-like objects that are kind of also sitting on the periphery. And yeah, vital signs are stable. We'll be there in 5 minutes. Now, that sounded silly, and there was a point. And the point is, wouldn't you want to know that I was bringing you a hamburger? I mean, that was the whole point. Should have probably opened with that. Then everything else would make sense. And the reason I kind of do it, that demonstration like that, is we listen to reports a lot of times in the hospitals in our areas, and without any exaggeration, people can be bringing in a resuscitated cardiac arrest and get through so much of their report before they even mention that, oh, yeah, hey, by the way, we returned ROSC on this patient. But they've gone through listing all of the vital signs. They've gone through age, sex, current heart rhythm, current 12-lead status, glucose, body temperature, things like that, GCS scores. But somewhere in the bottom is they will then add in patient was in cardiac arrest for 15 minutes and we've got ROSC. And hey, by the way, we're going to be there in 10 minutes. We don't want to bring gifts, surprise gifts to the receiving hospital. There are so many different things that have to happen on the hospital side for them to take that patient and get the resources in place, get the things that they need to have at bedside and all the specialists they need, that we need to put that stuff up front. We need to establish the priority of the communication. Of course, it's going to vary from patient to patient, but I would suggest if you're bringing in a patient that you know is going to require special resources, whether it's a stroke transfer, whether it's a patient who's septic shock, a trauma, a patient that was in cardiac arrest, especially if we want to talk about on the critical care transport side, if you have an active balloon pump, they'll probably want to know that. If you're running ECMO, and I've seen the ECMO train kind of roll in a couple of times, from an ED perspective, you want to know these specialty patients are coming in because you need to get all your stuff in place. You need a room for them, you need the doctors. And here's the thing, if you have one of those long, rambly reports, we're all human. Despite our best efforts, it's really quite likely that whomever is on the other end of the radio has probably tuned you out. Maybe they'll snap to, maybe they'll come in afterwards after you say, hey, by the way, this patient was in cardiac arrest 10 minutes ago, and now they're struggling because they had tuned you out the entire time thinking, okay, this sounds like a stable patient. There's no reason to kind of pop my head up on this. And now, wait, what? Cardiac arrest? Hey, wait, huh? So start big. Make sure that we're not bringing surprises to the hospitals. Make sure that we're letting them know, and kind of go with that. As a general format, what I recommend to folks, and this is something that you can use and coach and mentor as well, just structure, unit affiliation, age, sex of complaint, chief complaint. I always make sure that chief complaint goes up, initial findings, initial vitals, how long I'm going to be in, any special considerations. Is this a bariatric patient? Are you going to need a medical translator? Is there going to need to be somebody that they wouldn't normally have, or something that they wouldn't normally have at bedside when we roll in? And then end the report. Are there any questions? There's one big asterisk though, and that's a big asterisk. But obviously, each hospital has their own bias. Each hospitals have different systems they want to use. Different charge nurses, even within the same hospital, can look for different things. I've worked for the system that I've worked with. I can recall a couple of the charge nurses, they only wanted you to call in if you needed a high acuity bed. If you didn't need a high acuity bed, they didn't care. Just roll in, go through triage like everybody else, save them the trouble. And then there's others that if you would done that too, well, I wasn't expecting you. Another thing as well, different hospitals have different systems. I go to a number of different hospitals in North Carolina, and the one that I mainly go to, It's a very informal process. It's very much a, hey, is there any specific alertness to it? If there's not an alert, then fine, we'll just see you in 5 minutes. They don't want the full vital signs. You can just get away with saying vital signs are unremarkable, and they're more than happy for that. And another hospital that we go to less frequently, but it's certainly on our periphery, they want they want everything on every single report. They want every single vital sign. They want glucose. They want respiration rate. They want SAT. They want pulse. They want blood pressure. They want ECG reload. They want it all. And when you get there, they've written it down. They hand you the form and ask you to verify what's on there. Okay. But from my point of view, I'm not sure which hospital I'm going to. So on a day-to-day basis, not on a call-to-call basis. So you have to be cognizant that each different hospital has different things they want to do. Get to know the hospitals in your area, get to know the receiving teams in your area, and kind of what would they prefer? Because again, it's about efficiency. And I know this one hospital that wants the whole story laid on them every time. I know at least 2 hospitals in my system that have no time for that and don't want to hear that. So I have to change the way that I approach calling into the various different hospitals in order to kind of deal with that. And whether that's right, whether that's wrong, not my place to kind of comment on that. It's simply, that's the way it is. So let's just roll with that. Similar to that, kind of similar, but not so, talking about patient handoff. And this is where, when we're talking about continuity of care, that getting to the bed, getting that receiving team in there, this is where it becomes really important that you hit everything that you need to hit. A lot of times, I think we've all seen that kind of idea where we'll start talking and more people will filter in and ask you, well, hey, can you start over again? Or this doctor wasn't here, or this nurse wasn't here. So one of the things I always am coaching folks and encouraging folks to do is to start off any handoff and report at bedside with a simple question: is everybody here? And then, is everybody ready? That way you make sure you're telling the story one time and that everybody is paying attention to you. One of the conferences I was at last year, I was talking with somebody from out of state, and we were talking about just general issues with trauma handoffs, and they were talking about this hospital. I wish for the life of me I could remember which one it is, but they had this one feature where they had this red circle on the floor of their trauma bay, and when an EMS or a receiving crew would come in, the person would stand on that spot, and the whole team knew if a person was standing on the spot, everybody had to be quiet and just listen to that person. So the EMS crews would know to come in, stand on the spot, and everybody was trained to be quiet and listen as the report was given. And that was a really cool idea. I don't think I could get any of my hospitals to even consider it, but I love the idea. But what we can do is everybody here, is everybody ready, and say it one time. And remember, if you've got a hamburger, start by saying, hey, I have a hamburger, here's what we go. Again, with a structure for doing a patient handoff, this is going to be a lot more in depth than what you would want to do doing a radio report. Always start with the patient's name. There's a couple of practical reasons for that, and then one kind of more emotional reason. But the practical reason is you've got registration, you've got the nurses that are charting, make sure that they've got the right report open. It's a step of confirmation that, yep, okay, I've got John Smith's open, okay. But as well, you're giving the entire team, you're introducing the person as the patient as a person. And they will always appreciate that. And a lot of times the doctors, the more savvy ones, especially as they move into attendings, will always want to address that patient's name. And very commonly, this is John Smith, and the doctor will immediately turn over and whisper, hey, John, how are you? How can we help? We're going to listen to him, get back to you. But it allows that connection to build, and it starts building trust. So it's a simple little thing, but start with that, and it has really cost us nothing, get a great return on it. Start with the chief complaint, if you can, and there's no reason you can't. But, hey, I'm bringing you this hamburger, yet. I'm bringing you a patient with cardiac return of spontaneous circulation after an hour of working in the field. Here were my findings. always start with the initial vitals, pre-interventions. And this is a simple mistake to make. A lot of people will give the most recent vitals after we've done everything, after everything has done. And that doesn't really give the story of how sick the patient was initially. Remember, during this handoff, the person that's receiving the patient, the physician, the team, is trying to calibrate how sick the person is, what their next steps are going to have to be, the things that they need to do. And if you start off by saying, well, blood pressure is 120/60, they're suddenly not so worried about that trauma patient. They're like, okay. But if you say this person was hit by a car, initial BP was 40/20, I guarantee you have their attention now. They know how sick this patient was, and this is a much more critical thing than it was a moment ago. So always make sure you throw the initial vitals before you've done anything up there on front. Initial blood pressure was 40/20. GCS was 3. They were breathing about 6 times a minute. Talk about what interventions you did. Now you're going to list through them. We intubated the patient. We decompressed the chest. We've had to decompress it a couple of times too. We are seeing blood come out of that. Lung sounds still diminished on that side. The other side's good. EKG. These are the things we've done. We've got IV access, IO access, what have you. We've done TXA infusion. Here we are. And then add the current vitals. Now you can say, okay, after everything we've done, we've got the blood pressure to 120/60. GCS is still 3, but they're breathing on there. They're fighting the tube and kind of trying to breathe, but we're still breathing for them at 10 times a minute. But now we can at least show that what we have done is working. So the physicians and the receiving team are able to say, okay, we've done this stuff and it's worked. So they're able to calibrate their expectations better. They're able to calibrate how they're going to approach providing further care to this patient. And one thing I will always do is always end with, are there any questions? And I do that to give anybody the opportunity to ask questions that I didn't address. Maybe they didn't hear. Did you get a glucose on this patient? I did. And I never add in, I already said that. Just smile. A lot of chaos, a lot of things going on. But just kind of give that opportunity for them to say and ask for anything else. So that's kind of a brief overview on the importance of the communication aspect of it, whether it's radio traffic, whether it's patient handoff, or even communication amongst team members. Are there going to be does anybody have any questions or anything they'd like to talk about before we move on into documentation?
I mean, we got.
No.
I got no questions.
Thanks, Rob.
So there's a few.
Chris is back. Diane's picking up the problem. Okay.
Somebody's out there. Somebody loves us.
Does anybody know where it is today?
Not sure it picked it up. The question is on the floor. Does anybody know where Christina is today?
No, I haven't seen anything about her in a while.
Okay. I haven't directly asked her, but I thought she was going to be here today.
All right. All right. Now off to the fun and excited world of documentation. And there's only so much that we can do to kind of lessen the sting of it. For those of you that work in hospital-based programs, you know that the further closer you get to the hospital, the more documentation you have to get. Anybody who's been EMS in a while, remember kind of a run sheet that you could maybe do in 30 seconds. Now with the EPCRs and ESO, it can take upwards of 20 to 30 minutes. If you have to do anything on Epic, I'm sorry. We'll send you coffee for next week. But documentation is such an important part. And there's really 2 main rules about documentation. They're immutable, that you've got to be done. If it's not documented, it never happened. And if it isn't documented properly, it didn't happen. Sounds trite, sounds silly, but the first time you get gigged on something, the first time there's a negative outcome as a result of something that you improperly documented, it'll be the last. You'll learn that lesson real quick and you'll be like, okay, I'm never going to do that again. So anytime that you're trying to do, doing any documentation, always try to be thorough as possible, but be concise. a tough line to cross, especially when you talk about the narratives. One of the good things, and I say good kind of with an asterisk on it, one of the good things about the documentation programs that we use, the electronics, is that so much of that is just rote memorization, just rote repetition, where it will tell you the information it wants. There's not a lot of judgment that we have to place. There's not a lot of discretional areas that we have to include in that. The odd box will pop up. Obviously, our narrative is a whole other thing, but most of the part, it's just very simple stuff. Here's your demographic part. Here's your response part. Here's your mileage, because we got to build this part. And then moving through the vital signs. But it's really important that we get all of this right for a number of reasons, some of which we'll talk about. When you're getting down into doing your vital signs, always make sure that you're recording vital signs at the intervals that your service will recommend or demand, and a lot of times it's dependent on the patient condition. If you've got an acute patient, every 5 minutes is probably the goal. It's the standard. If you have a non-critical patient or one that doesn't require a lot of ongoing stuff, maybe you can get away with 10 minutes, maybe you can get away with 15 minutes. But really, just make sure that you're doing every single time that you do that vital signs, make sure that you're documenting everything that you possibly can. And don't forget GCS, and don't forget pain score. Pain score will be hugely important here. We'll talk about that specifically here in a moment. But make sure that every time they're doing an entry for vital signs, you should at least have most of those. If you're not running capnography, that's fine. But everything else, you can always have, and you should have every 5 and 10 minutes. That will really help. Now, when we come to talking about the narrative, that's going to be really different from agency to agency to QA director to QA director, even sometimes from crew to crew member. And I'm not going to tell you, hey, do it this way, do it the other way, do this method, do that method. I'm going to say, make sure, try to calibrate what the agency is looking, or what, what your hospital company wants you to do, what your flight service wants you to do, or what your ground service wants you to do. And then remember, you're painting a picture with that. You can be as descriptive as you wish, but I would advise you to be cautious, because remember, everything that we write down and document is going to be part of the whole patient record. This is going on this patient records forever. It's going to be there for forever. And anybody can look at that. And we'll talk about some of the people who will look at that as we go. So while you might want to put in, patient wrote copiously all everywhere, which was a red and green color, you might want to do that. It may not necessarily get you as far ahead as you want, because while the QA person or person who's reading the ticket might read it and snicker and know you were making it funny, when the billing company or any of the other folks look at this and see this, they might think you unprofessional. And you really want to try to avoid that on any circumstance. When you're talking about writing your narrative, tell the whole story from the way it was taught to me and the way that I've seen it. Is keep in mind one of the main consumers of your narrative is you've got your receiving hospital, you've got the billing, but there's also a really good chance that your narrative could be Exhibit A in a criminal case, or a criminal or a civil case in some regard. So they'll take that and they'll put it up, and then a whole bunch of people who have no business, no experience in EMS are looking at that and trying to decipher what you said. So one of the things I would say is, if you're the type of person that really strongly uses shortcuts or abbreviations for everything, consider that. Consider maybe moving away from that, or at the very least, make sure that your abbreviations are in standard and documented somewhere with your agency, so that if it's somebody else looking at, they can look up and be like, okay, that's what this means. The format is irrelevant, dictated by facility standards and agency standards. Some agencies want their narratives, your narratives, to be a specific way, whether it's SOAP, whether it's chart, whether it's a fusion of all something else. Just kind of find what your agency says, and if they don't care, then make your own way. Just make sure you do it the same way every time. That's how you get quick. That's how you get efficient with it and cut down and minimize potential errors. I got a bullet point here about duplicating information elsewhere in the EPCR. I've been party to a number of discussions about that. Should you do it? Should you not do it? An individual I used to work with who has significant experience in the law side of it. His opinion was always, you never duplicate information, because if you think about it, if I've got it written in the narrative one way, I've got it written in another box another way, I'm creating a discord in my own ticket. And should anything go wrong, that will become irreconcilable, that he wrote it here one way, here another way. Which is it? Okay, let's just throw the toll ticket out, because we can't tell whether or not the person really knew what they were doing. And if the whole trial is about determining whether or not I really knew what I was doing, that's not a place that I want to be. What I would say is, if you are going to duplicate information, make sure you're checking. Make sure you're going back and forth, and that information is perfectly in sync with each other as we go along. Kind of a little detour here, but for those of you that work in, especially those of you that work in hospital-based systems, whether it's air, whether it's ground, whether that's a goal of yours, but even if you're still in street EMS, this is something to consider. So patient satisfaction scores. Not aware, every time a patient has an encounter with a hospital, if they're part of the Medicare or Medicaid program, following discharge, they're going to get a survey sent to them by the Medicare or Medicaid office, asking them a whole bunch of questions about their care. Were you satisfied? Did your doctors give you everything you needed? Were your nurses nice? Was the facility nice? Do you feel that your pain was treated well? And other questions of that nature. And here's the kicker. Depending on that patient satisfaction score, so arbitrarily pulling numbers, let's say that the patient rated their whole trip a 6 out of 10 through the metrics, and it comes out to be the 60% satisfaction with the hospital. Medicare and Medicaid, by law, will pay that hospital 60% of the bill that they put in. And what that means is patient satisfaction and how well that patient is going to answer that survey has become a very, very important metric and an important thing for hospital administrators nationwide. They want that 100% recovery of what they've billed. They need the patient to be satisfied 100%. As a result of that, if you're wondering, why there's always those, we strive for 5 signs in the various hospitals, and so much attention to given to patients' pain, that's one of the big overwhelming things that comes back over and over again, is that the patient feels that their pain wasn't managed. As a result of that unmanaged pain, their satisfaction score that they're going to give that hospital is going to be lower, and as a result, the hospital is going to recruit less money off of that patient simply because that patient wasn't satisfied. So what we can do as providers, obviously we can only address what we can address in the time. We can't really be held responsible for the whole course of care. But when I mentioned making sure that you're measuring pain at every single time you take a set of vital signs, make sure that patient's pain is documented, because it's a big deal on the other side of it when the hospital company or the billing agency wants to recoup as much money as possible from the care that was provided across the line, that we can at least say, well, her pain was managed through us, so the transport division should get everything that it's asking for. And then since we lost this up in the wards, they can argue about who's not getting paid for not treating the pain. Additionally, kind of a segue to that, if you're wondering why pain control is so aggressive, and if you've kind of noticed over the last year that pain control has been more aggressive and more at the forefront of talking, it's a result of this Medicare reimbursement structure. I was looking through some of the data yesterday, or some of the laws from Medicare and Medicaid about it yesterday, and they claim it's only 1% of all stuff that we withhold, and then they have 1% of Medicare and Medicaid billing for an entire year would be enough for all of us to be retired for the rest of our lives with our own island down somewhere in the South, more tropical places. It's a lot of money that's changing hands. So a little bit of segue, but make sure we're documenting pain, make sure we're doing everything we can to manage our patient satisfaction and documenting that to help overall with Medicare reimbursement, Medicaid reimbursement, and overall insurance. For those of you that are working in field EMS, at the moment, this billing structure does not apply to ground-based EMS services, specifically 911-based EMS services. However, it has been floated, and individuals much more in tune with this than me suggests that this is an inevitability that will happen to us too. So we can look forward to that possibly in another couple of years. So when we we write our ticket, we write our documentation, who are the primary consumers of that documentation? You've got a number of different folks. Obviously, the receiving medical team. We've talked about continuity of care already a couple of times, and that's what they're looking for. What was done? What responses were done? Do you have any allergies listed that we don't? Do you have any medications listed that we don't? What tried? What was said? What was done? That's a pretty common one. The QA/QI team, which we'll talk about here in the next segment, but they want to take a look at they'll be consuming your tickets, looking at them. Was everything within standard? Was everything done in the appropriate time frame? Did we hit all of the marks? The billing department is going to be one of the consumers. They're going to be one of the ones that are taking a look at that, working on coding it, working on making sure that we get able to bill for it, get our recompense for that, as well as lawyers in the event of any sort of issues. They will also be consuming our tickets or taking a look at them. We'll just kind of go through them all individually. Most of it really simple, makes a lot of sense. Obviously, receiving medical team, who, what, when, who, what, how, where, why. These are the folks. What did we do? Exactly what I just said. What kind of vitals? What kind of response to treatments? What treatments were tried? QA team, again, all appropriate interventions get done. Why or why not? Remember, if you choose not to do something that's indicated or maybe protocol based or maybe policy based, always make sure you're documenting why your decision, why you didn't do it. It'll save you a trip to the QA office, but it'll also maybe help further down the line too. If you withheld medication due to concern over patient's blood pressure and noted variance over the last 20 minutes. It doesn't have to be complicated, but at least give them an idea that I just didn't feel good about where this was going. And any complaints. Obviously, patients complain all the time. That's their right, and oftentimes they're right to complain about certain things that were done. But the first stop is going to be that QA/QI team. Pull that ticket, look at the care that was rendered, look at the patient condition. Was everything appropriate? Was everything done properly? And the vast majority of patient complaints never make it to you. If you've got solid documentation and you're up on it, they might be able to look at your ticket, listen to the complaint, and deal with it, unsubstantiated or even substantiated. But if you've got good documentation, a lot of times it will never even come down to your level. Billing department. So billing department this is how we get our money. We can say what we want about the importance of what we do, the rights, how wonderful it is for us to do our thing, everything that we have. We've got to pay for for medications, we've got to pay for salaries, and that money has to come from somewhere. And that's, at the moment, that's billing insurance, that's billing the patient. So we need to make sure that we're billing correctly. So the billing department is going to take a look at your ticket, break it down to see which ICD-10 codes can get used with it. If you're not familiar with ICD-10, that's the kind of the national standard for billing different encounters, and for a different encounter, which procedures are authorized to be billed, which are not authorized to be billed, how to code out the procedures. I'm just going to point at that iceberg over there, the ICD and the 10 coding, procedure coding, be like, yeah, that's an iceberg over there. It would take about a week to go through all of the intricacies of that. And I'm really, really glad I don't have to do it. A lot of times it's auto-generated by the tickets we make. ESO is a good one for that. It's one that I'm the most familiar with, but it will pull out all of the codes based upon the primary impressions, the flow chart items, the vital sign items, and actually there's an algorithm in the software that takes it and just generates that report. They got to be able to figure out why a procedure was done. A lot of times, if it's part of what we would normally do, we'll never hear about it. But if you do something kind of a little bit out of, I don't want to say out of bounds, but kind of more on the periphery, deeper in the protocol maybe, or kind of to the side, make sure you just put in there, administered this medication due to concern for this. Keep in mind the people that are doing the billing are not likely medically trained. And when I say not likely, I was being generous with that. The folks that work in medical billing don't have any medical training by and large. Maybe a supervisor of a unit does, but the person that's doing the day-to-day billing, and they don't know what our job is. They don't know how to do our job. They're just looking at data. Is this written here? Yes, no. Is this written here? Yes, no. And then they'll kick it back if the answer is not there. And when we talk about the narratives, the importance of having everything documented together, remember these guys, they're not able to read minds. They're not psychics. They're not able to intuit automatically why we chose to go this way or why we chose to go that way. And finally, the last major consumer is going to be the legal department. And these are our lawyers. And it's not all bad. In fact, a lot of times when these guys get involved, it's not necessarily anything we did. It's a lot of times billing disputes. You billed me for a procedure I didn't do. I'm going to have my lawyer countersue. I'm going to have get these people involved. Sometimes, yeah, malpractice, but that doesn't mean that they're saying that we did something wrong where we are. If you had a patient was brought in by EMS to a vehicular accident, say that the accident was caused by another person, EMS treated the patient appropriately, took him to the hospital emergency room, the trauma team took him, treated him appropriately, put him in the ICU. The ICU, he expired through no fault of the ICU. That's still based upon, depending on the circumstances, that initial motor vehicle collision, that's still a likely ticket that's going to get pulled by lawyers of the survivors or maybe lawyers of the defendants. And they're going to take that whole medical, the whole medical history from start to finish and look through your tickets, look through the ER's notes. And again, they're not necessarily looking for, I'm just looking for one person that I can pin this on. They're trying to build that whole story. They're really, most of the time, unless we step out of line and willfully and intentionally will do something grotesquely out of bounds and grotesquely intentionally to harm a patient, the lawyers are honestly on our side on almost every single case. So just make sure that the way we keep them happy and keep everybody happy is by ensuring that our documentation is tight, ensuring that it complies with any standards that the hospitals might have in the format that they prefer, and making sure that it's documented as concisely and as thoroughly as we possibly can. That means not cutting any corners. That means making sure that we have all the stuff in the boxes that we need. And that's going to be the end of documentation and communication segment. Are there any questions? Okay. Now, last time I closed out of this is when I accidentally dropped the feed. So let me make sure. Let's see if I can improve it this time. Okay. Maybe. Yeah, okay. I'm going to take, it is 2:15 right now. I'm going to start this last segment at 2:30. So in 15 minutes, we'll come back and we'll start at 14:30, the QA/QI segment. And once that's done, we'll be done for the day. All right, so we'll see everybody back then. Segment where we're going to talk about quality assurance versus quality improvement. Just kind of go over some of the brief concepts of the two processes, how they're different, how they're alike, and most of all, why these are things that we shouldn't be fearing them. We should be embracing it. We should be helping it. We should be looking at it as at least a force for positive change if done correctly. That said, working for the agencies and coming up with that I have, and I totally understand the spy versus spy nature of both of these agents as things that kind of at least elicit an eye roll or a groan. I'm with you. I get that. But if it's done correctly, both QA and QI can be huge benefits to the agencies, to the providers, and kind of the whole way around.
Mad Magazine still in print?
No.
Okay, so children watching this don't know what you're talking about.
But you can find them on YouTube.
Okay.
Okay, maybe the spy versus spy reference is dated. I get that.
There's a few children, it's mostly adults.
So some of the things we'll talk about, the importance of having a strong QA/QI process, some principles of quality assurance, talking about bundles, the concept of bundles, clinical care bundles, and how that applies to QA, QI, data management. Principles of quality improvement, well, the differences there, how one feeds into the other, how we're going to utilize data, and how we're going to use the information that we glean from all of this in order to drive an effective training program to ultimately benefit ourselves and our patients most of all. So a lot of times QA and QI get intermixed in a lot of agencies, a lot of facilities. It's the same person that does both. Understanding though, they are two very separate jobs, and they both start from, at the simplest level, they both start from two different questions. When we're talking about quality assurance, that's asking of the question, how are we doing? How is the system today? How is the care that we're delivering? How are we meeting the standards? Quality improvement is asking the question of how can we do better? How can we take what the data is telling us from quality assurance, and now that we know how we're doing, how can we drive it forward? And as medicine evolves, as healthcare evolves, and as our responsibilities evolve, we need to be cognizant that, you know, it's a much different, much more changing world. Once upon a time, we could simply say, and if you've been doing this for a while, you've probably heard it, even if what happens in the back of the box stays in the back of the box. One of the most pervasive, and that always struck me wrong, I hate it as a phrase, but it used to happen, and it was part of the culture, that your reports, we didn't document as much, and if an error was made, you didn't want to write it down, and that was a long time ago. Today, we have so many different competing methods that we're going to be held accountable to, if not by our agencies, then by the court of public opinion, by the patient, how that all goes together. But it's certainly with social media, the availability of phones, recording devices, all of this is really kind of changed certainly how easy it is to catch somebody doing the wrong thing or to record something. So certainly we need to be cognizant of that. And if this is the force that makes 100% honesty in every situation, I'm for that. But it certainly does mean that the days of what happened in the back stays in the back are completely gone. And I think that's a good thing. Your mileage may vary. So quality assurance, talking about accountability, looks at the maintenance of standards. We have standards of care for a reason. Are we meeting those? Did we manage to deliver the right care at the right time? Basically, you know, are we doing things right, or are we performing CPR like this? That's kind of where QA is coming from. And QA has a very important kind of role and part. This is straight from EMS.gov, which is kind of looking at, nice little typo there. This is from EMS.gov. And it kind of reads a whole bunch of legalese, but essentially quality measures and how we measure up and how everything works is hugely important. In terms of, we talked to the last module, we talked about billing, recompense, we talked about accountability in terms of patient satisfaction. But from here, QA is done at the national level. And I got this video from EMS.gov that kind of goes over how our data is used. And if you're in QA, the data, EPCRs, reports, that's your bread and butter. And so if we learned it from last time. You know that documenting patient care is important, but So I will admit, when I watched that for the first time, I got a little bit of heartburn over the part where they say, you know, eventually good documentation means we can give you safer ambulances. The implication being, of course, that bad documentation, no, keep driving around in your death traps. But it does all link together how our data works. And QA is the first line of that. Yeah.
Every county on the face of the planet finds the lowest bed ambulance routinely.
Mm-hmm.
That's a falsehood. However, getting paid by Medicare, Medicaid, and insurance companies theoretically does contribute to our paycheck.
Mm-hmm. So QA, when we take our metrics and and by metrics, we just mean data. It can be the more common ones, arrival on scene, reflex time, time from dispatch to wheels rolling and responding to the call, response time to the call, time on scene until transport with a trauma patient, time on scene until transport with a stroke patient, any of those high acuity patients. The AHA's got a good one in there, a couple of time from administration of aspirin, percentage of patients who receive aspirin that have chest pain, things like that. Those are metrics. Those are the data that we're looking at. And how does our system do against national standards? How does the system do against hospital standards? If you're hospital-based, a lot of competition between the hospitals, and the ability for one hospital to definitively say, hey, we're better than this other hospital because look at our metrics. If you don't have the data to prove that up, if you don't have the quality assurance to make that happen, you can't make that claim. And it's a big money game. It's very high above our level as providers, whether we're in critical care or otherwise. But it all does come back to increased income, increased billing, increased patient satisfaction, more patients coming in, which does have the trickle down effect of meaning more funds possibly available for us. How do we compare system against Medicare and Medicaid? And mentioned rival systems, but QA metrics, you always have that, hey, I'm a better system than you are. Well, how are you quantifying that? Is it because of the color of your uniform? Is it because they have one cool one-piece jumpsuit and we look like we get our clothes from the local tailor down the street? Or is it we do better with chest pain patients? Our cardiac arrest patients have a greater survivability than theirs do. In order to have definitive answers for that, you need data, you need metrics, and you need quality assurance to look at that and quantify how you're doing it. And how in terms of patient care, when we talk about QA metrics, a lot of times the talk is going to turn to bundles. And the concept of bundles is a very high level national standard type of thing. But essentially what it breaks down to is if you have a patient with a specific complaint, they're going to get X, Y, and Z interventions within a certain amount of time. So if you take a chest pain patient, for instance, one of the bundles as you go up high, look at it nationally, all chest pain patients get aspirin, they get nitro, they get a 12 lead within 5 minutes. They get quick transport, they get IV access, and they get all of these things. And anytime that there is, say this patient doesn't get aspirin, well, then that's a negative mark. That's a mark for, hey, why didn't this happen? Supportive documentation, this is where it ties into that. If the patient didn't receive aspirin because they got an allergy to aspirin, well, okay, we can exclude that from the data. If the patient didn't receive aspirin simply because a provider forgot, however, then that's an indication that at least on that given moment in time, that the system wasn't as good as it needs to be based upon national standards. These bundles, where they come from national associations, member associations of physicians, EMS administrators, nursing, and the various, I don't want to say special interests, but your AHA, your strokes, your American Stroke Societies. And bundles are driven by evidence-based standards and research. These aren't just things that people are randomly putting together and say, hey, let's make a bundle for stroke care and let's do all of these things. No, these things have been chosen because they all contribute to more efficient, better outcomes, better patient treatment. The stroke one, when I first saw it, I always wondered, you've got, neuro exam, are you doing whether it's Cincinnati or LAPS score on the patient? Are you taking them to a thrombectomy center? Are you bypassing a thrombectomy center? How quickly are you notifying the hospital? How quickly are you getting off scene? And hey, by the way, did you get a 12 lead on this patient? And did you get a glucose on this patient? And for my system, some of our transport times can be 5 or 6 minutes or less, depending on where in the system we happen to be, just because of the way that our city grew out. And you're sitting there and you're thinking, I have 5 or 6 minutes of transport to do everything that I want. And I've got to get off the scene in 10. So I have 15 minutes to do all of these things. This is what I'm prioritizing. I don't need a 12 lead on a stroke patient. They're stroking. They've got hemiparesis on the left side. They're drooling. They're unable to speak or swallow. Why do I need a 12 lead? Well, because of evidence that points to certain causalities of maybe the stroke patient's having a STEMI. Maybe it goes together. Maybe the stroke was caused by cardiac dysrhythmia. This is something that would affect the care. And where I'm kind of going with this is reinforce the bundles are there because of evidence-based standards and research. They're not arbitrarily made. Check with your receiving hospitals, check with your governing hospitals, look at the state level. I'm not sure if the state has specific patient care bundles, but the catch is if you're following the protocol and you're doing everything that's listed, you're going to be fine. We're going to hit all of our marks. It's not going to be an issue with that. But make sure to explain to the crews, hey, this is why we're doing this. Because if you've ever managed EMS professionals or supervised EMS professionals or trained EMS professionals or ever been, change is not something that's easy to do. And just saying, hey, I need you guys to do this now, instead of this thing that you've been doing for 2 years, 3 years, 20 years beforehand, always explain why. I find that explaining why at least lessens some of the initial heartburn and pushback that you get. Might not take rid of it all, but at least it's a start. But always make sure to explain that, hey, these are the standards because this is where we're getting them from, and this is where they got them from, and so on. How are we going to get QA metrics? They're going to come from a number of places. Primarily, they're going to come from things like your PCRs, random selection of PCRs. You could also have it set to look for Sentinel events. By Sentinel event, it's a buzzword in there that you'll see talked about a lot. But basically, high risk occurrence, HALO, high acuity, low occurrence situations. Things like STEMIs, things like acute strokes might be Sentinel events. And these are tickets that you look at and you look over the data. Everybody that has chest pain, we're going to pull those tickets to make sure they all got aspirin, they all got nitro if indicated. They all had vital signs taken. They all had 12 leads done within a certain amount of time. And our goal as a system is to do this 90% of the time. It is important to set realistic goals if you're in a position to look at your agency and say, I want to make sure that we can hit 12 leads in under 5 minutes in all of our patients. It might take a little bit of work, but maybe you can do it. But it does help to keep a realistic expectation. Are you going to get 100% of that? You're absolutely not. Why? Because we're trying to get people, especially if you're in pre-hospital, types of situations. Sometimes it takes you 7 minutes before the patient will sit down in a chair long enough that you could even think about touching them. And if 100% is your goal, you're going to be very disappointed. So it's always good to set realistic expectations. Look where you are now. Look at improving incrementally. But when you're taking a look on how to get those metrics, take a look at Sentinel events. Do random selections. Just randomly say, I'm going to take 6 random tickets, check them over. How was the patient care? How did it sync up with protocol? Is there anything we can learn from this? And then ultimately, self-reporting. That's a huge part of it. I think you don't go through an EMS career without making mistakes. You don't go through being human without making mistakes. The key is that when you make a mistake, that you have the ability to kind of own up to that, to walk up and say, hey, this patient that we had, I should have went left, instead I went right, and here's what I gave. I've been thinking about it. This is how we should have gone. And how that conversation goes has a lot to do with the overall culture of the agency, how things are going. So number one, question to ask yourself and to ask your system, can you admit your mistakes? If you made a mistake today while doing patient care, whether it had an adverse patient effect or not, are you able to go to your supervisors, your QA team, and anybody and say, hey, look, I made a mistake. This is what happened. Can you do it? And what would prevent you from that? Well, if you're worried that they have a tendency to, anytime anybody makes a mistake, to replace them, to drop unseemly loads of paperwork in people's personnel files, if that's the type of culture that you have, you are going to have a really hard time in achieving any sort of excellence in terms of meeting metrics and exceeding national standards and really pushing the envelope. And by nature of the individuals who are taking this course, all of you, obviously you're interested in moving beyond. You're interested in pushing yourself, so in bettering yourself. So that becomes a really important question. Can you admit your mistakes? And if not, what barriers may exist? May it simply be the person that does QA has a personality more suited for perhaps other occupations? Is it that the agency has a history of cutting ties with anybody who has a negative performance note or a negative issue? Because if that's the case, why are you having humans work with you? And I say that kind of rhetorically, but we're going to make mistakes. We all make mistakes. It's just part of what we do. The older we get, the more experienced we get, the less mistakes we'll make, maybe. But the fact of the matter is, at some points, you are going to make mistakes. I do have a comment on here about just culture. Just culture considerations, and just culture itself as a concept is it's not necessarily controversial, but it's a huge talking point, and I'm not going to do too deep of a dive into that. It is a thing. It is its own thing. That's why it's hanging out there in quotation marks. It originated in the FAA, the pilots, and essentially what it comes down to is it is a method of evaluating error by a provider where the error could result in somebody's death. Don't really like to think about in terms like that a lot, but what we do does matter. Negative outcome on our part or negative decision on our part could potentially have the ability to kill somebody. We do have that trust and that level of engagement with how we're affecting our patients. And just culture is a methodology used in terms of, I don't want to say investigation, potentially discipline, that looks at how the mistake was made, why the mistake was made, whether the mistake was made as a result of an individual's intentional action, unintentional action, whether it was a mistake of the brain, the hands, or the heart, is a trite way of kind of putting that all together. Is the hands, was it a simple mechanical mistake that could have easily been fixed? The head, was it just memorizing a number wrong, recalling a number or procedure wrong? Or was it the heart? Did this person truly mean to commit harm, commit an intentional act, truthfully and intentionally violate a protocol, a procedure, things like that? And just culture as a concept looks at that, but it feeds into the QA, and I've got it jammed in here on purpose, because if you're not able to admit that you messed up and that something happened, if you're not free to that and without fear, and the big thing is without fear of your job being taken away, are you or I more willing to do that? Certainly we are, but we know that we work with folks that don't for a variety of reasons, whether it's desperation, whether it's just character-based flaws. Not everybody is always as concerned in being as upstanding as we'd like them to be. But some of that is also the fear of repercussions. So if you want a truly successful quality assurance program, you need to ensure that there's no barriers to coming forward and saying, hey, look, I made a mistake. This is how we're going to go. This is what I did. Just culture specifically has that in there, and that any error that is self-reported by the employee when determining discipline, termination, is heavily disfavored to the point of almost being eliminated in all cases. So having that ability to self-report, knowing it's not going to cost my job, it's not going to cost me money, really encourages folks to come forward and look to be better and not be afraid of moving forward. So when we're talking about QA culture, we've got to encourage ownership throughout all levels of the agency, whether it's the provider that's just stepping into the street or stepping into the agency on their first day, to the person that's been here for 20 years, to the director, to all points in between, that the agency, how we do things, it's owned by everybody. We need to encourage that, and we need to make sure that everybody understands that you're vested on day one. Because by doing that, you're making sure that everybody's voice, everybody's opinion, and everybody's perspective is seen. Because when QA is going to make a change, or when an agency makes a change, it affects everybody. You can't just say, hey, today we're doing 15 leads. We're going to do right-sided, and we're going to do lateral wall or rear lateral wall looking at everybody with 15 leads and be like, okay, that's how we're doing things now. There's going to be a ton of people that are like, now I've got to not only, it took me 7 minutes to get the person to sit down the first time. Now I've got to get to their back and do more. No, that's not happening. Whereas we want to make sure that we're doing this change, we need to let everybody know that, hey, we've noticed that we've been missing a lot of right-sided MIs recently. We'd like to make this change that everybody who gets a 12 lead will get a 15 lead. I know it's going to take you more time, so we're going to set a secondary time. You know, if it's 5 minutes to that first 12 lead, it'd be another 5 minutes. At some point in the next five minutes after that, let's get that 15 lead. And that affects since we know it affects you, we want to give you guys an opportunity to know why we're doing it. And these are some cases that we saw. And how you approach stuff and how you phrase stuff really helps. But make sure that we're talking to the providers and QA is talking to everybody. One mistake that I've seen, and I'm sure everybody that's watching may have seen at some point, is it's really easy when you move into a position like QA, like QI, or any sort of managerial oversight type of position to lose perspective on the job, to lose perspective on what it takes to actually accompany it together. It's really easy to get caught up with all of the numbers and all of the data and the percentages that you're hitting and the percentages that you're not hitting. It's really easy to kind of look at all that and go, okay, well, we're only 70% compliant with getting 12 leads on our chest pain patients. We're terrible, we're horrible. Nobody knows how to do their job. And you forget that a lot of times a whole bunch of different reasons can go into that, but you lose perspective, you lose sight. So always make sure that you're staying, keeping a perspective of what's actually the job is about. That will help. But also make sure that you're staying at the forefront of the knowledge. Stay abreast of current emerging trends in medicine. If things are changing and data and studies are showing how things are evolving, make sure that you are paying attention to that and can see it and can explain it. Anybody who's ever had a concept explained to them by somebody who doesn't understand it, not talking about me. If anybody who's seen something explained by something who doesn't really understand it, it's terrible and painful, and the message gets lost really, really easily. And most importantly, not most importantly, but something else, when you're talking about a QA culture, beware of silence. And what I mean by silence is when people are too afraid to speak out, when people are too afraid to say, I don't like how this is done, I don't like how that is being done. Or when people just don't have suggestions anymore, it means they don't care. I know that's trite, overly simplified, but truthfully, a silent employee or a silent a group of providers is a group that they've already got their resumes out somewhere. They're already looking for the next opportunity, and that should be a wake-up call that whatever has happened, our employees don't feel comfortable enough coming forward. They don't feel enough talking about anything, that they have given up. And what did we do as an agency? What did we do to cause that? So QA, quality assurance, should be a cultural thing. It shouldn't just be somebody in the office pulling tickets and telling you what you did right and telling you what you did wrong. It should be about everybody wanting to be better. Looking at it like, hey, we only got 14% of our witnessed cardiac arrests back last year. National standard is 16. What can we do better? And that should be something that drives us all. And those that it doesn't drive, we need to try to connect with them. We need to try to connect with folks and build that and encourage that in them. Because the flip side of QA, if QA is the how are we doing, QI on the other side, how do we get better? How can we get better? How do we questions, and it can start with a question. And they should always start with a question. So they can be as complicated as, how do we improve our cardiac arrest survival rate? How can we improve billing reimbursement? How can we get more money? How do we reduce transport times? How can we reduce patient complaints? All of these questions will start a long process to figure out, what can we do? So once you've asked your, sorry, go ahead. Once we've asked the question, now before we kind of go running off half cooked after something, look for trends over time. So if we're looking at the question of, how do we improve our cardiac arrest survival rate, look for trends over time. How has our
Martha. You can hear.
Sorry, folks. So if we're talking about how we can improve our cardiac arrest survival rate, take a look at it. How has it been for a couple of years? Where have we been for the last 3 years, 5 years, 10 years? Where historically have we been? Is there anything popping out? Have we always been 14% successful? Were we 17% successful last year, introduced a new protocol, and now we're 14%? Look for these trends. Identify where those deficiencies are. Are there certain pathologies, if appropriate? Are there certain types of patient presentations that we're just not doing really well with? Look for certain equipment utilized. A lot of times and I've seen a mistake, it's very easy to blame a provider for not doing something correctly or for something not working out, when the equipment or piece of equipment for the procedure that we're giving to them is just so, how shall we say, poorly designed for the task that it's creating a barrier by itself. Certain times of day, that's more aiming at, is it certain shifts? Is it certain night? Is it a day thing? Is it, hey, I've been up for 20 hours and yeah, you know what, my first pass intubation success rate does in fact take a little bit of a dive at 3:30 in the morning after having been providing care since 7:00 a.m. the day before. I can understand that. But from a system of how do we get better, we need that. What can we do as a system to get better with that? And it may be simply put on different trucks, get more sleep, things like that. Barriers to care. What systemic issues are we creating? Are we giving people bad equipment? Are we giving them unclear expectations? Are we giving them procedures and protocols that don't make medical sense? Are we creating any barriers that need to be overcome? Once you have your question and you've done your research on it, it's time to kind of take that and to put it into action. And the Plan, Do, Study, Act model is a nationally viewed and nationally respected model for taking the QA process, implementing it, and essentially what you're looking at with Plan, okay, we're going to increase cardiac arrest survival rate in witnessed VF, VTAC arrests over the next calendar year, starting as of January 1st, 2020 to 2021. How are we going to do that? We are going to provide increased training. We're going to work with our partner agencies. We're going to work with our crew members, make sure they understand the importance of compressions and things like that. You know where I'm going with this. Study. This is what our research has shown. Bring it out to everybody and then act. And then you make that, you put that into effect, you let it run for the year, and then you take a look at it afterwards and you say, okay, where are we? So that's now January 1st, 2021. How did it go? And if it went up, then great. But this is a long game, and you've really got to avoid trying to look for a quick fix on this. You've got to settle in and feed into training, give training the opportunity to reach all crews, answer any questions, all providers, make sure that stuff gets out there. Another question we could ask is, it's important that when you know the data, when you have it, knowing how to interpret it does help. So just looking at, for those of you that are not familiar with the county that I may or may not work with, what you're looking at are strokes and confirmed strokes over the calendar year 2016 to 2017 by where we responded to. And if you don't know how the county is situated, you don't know where the vehicles are located, you don't have the context of it, it's really easy to say that, hey, nothing goes on in all of you look in the northern parts of it, and yeah, our city is centralized in the middle. But just because we're looking at strokes doesn't mean that calls don't happen in some of the blanker areas.
Or BFE.
And one of the tricks is that, well, only the trucks that are in that central spot, they're the only ones that they're going to do strokes more than everybody else, so they should be better than everybody else. That doesn't work out that way. We're dealing with people. We're dealing with different assignments. You've got to be effective at implementing any sort of QI program. You've got to look at the forest and you've got to look at the trees. If you're familiar with the expression, can't see the forest for the trees, it's referring to somebody who's so short-sighted, all they see is a tree, and they're unable to kind of appreciate that this tree is part of a forest. The converse of that is true. You're looking at the forest and you kind of forget that there are individual trees in there. For truly effective QI to work, you've got to be able to look at both. Knee-jerk reactions. I'm just avoiding knee-jerk reactions is a huge managerial mistake. It is an excellent way of torpedoing a lot of goodwill and a lot of progress in an agency by you have one case or you have one occurrence and suddenly you're going to change the rules as a result of that one case. Avoid that reaction, do the research, look for the national standards, understand what is good data, understand what is bad data. If I was to look at if I was to use this map here to justify where my vehicle location is based upon call density, I'd put all my vehicles in the center of the map and wouldn't have much left for everything else, when I know that's 220 square miles and the hospital itself is actually buried under one of those piles of dots. Actually, two of our hospitals are buried under piles of dots there. And the whole county needs to be covered, not just the special places. And are there any barriers to care that have been systematically placed? I don't want to beat that one to death, but it is absolutely a question that needs to be asked of what are we doing? Can we do better? Anybody familiar with the SMART goals theory? I'm not going to take too deep of a dive into that. Again, it's a national standard type of thing. Going through that. But if you're making a goal, anytime you say a goal, it has to be specific, it has to be measurable, it has to be attainable, relevant, and timely. Talking head types that are giving speeches nationwide are being called in as executive consultants or whatnot. They're constantly talking about SMART goals. And if you're going to set any sort of goal, anything that we want to do better, it does really help. There is a lot of measure of truth to this. If I want to raise my cardiac arrest survivability rate and witnessed VTAC arrests, I want my goal to be all of those things. If I'm sitting at a 14% survival rate with the crew that I have today and the agency and everything that I've got today, and say I want to improve it, I'm not going to turn around and say, you know what, the national standard is 17. I want to be better by the national standard. So I want a 20% survival rate in witnessed VFib arrests by the end of the next operational period, end of the next year. Well, is that specific? Yes. Is that measurable? Yes. Is that attainable? Absolutely not. Even the best agencies in the entire nation are only able to pull off 19, and that's with more than a decade of work and indoctrination and training into it. Is it relevant? It might be. Is it timely? Well, sure. It is something that we're looking at now, and it is addressing a need we have now. We're giving a year. Okay. But it's not attainable. So from a SMART goal perspective, we can quantify and we can say that is not an effective goal. Now, if we're sitting at 14% and we want to say, you know what, let's increase it by 1 percentage point, that would turn that unobtainable into an attainable. Should be able to get a percentage point out with that. And how are we going to do that? We're going to take our SMART goal, we're going to take our goal based upon everything we've looked at, and we're going to go to training. And we're going to say, hey, what training are we doing? What can we do better? And how are we going to work with that? Always look at your training department, your training folks and everything, and does our training meet our needs? So with this example I keep trotting out of the 14% survivability, our training meets our needs if we're okay with 14%. If we're not okay with 14%, then our current training doesn't meet our needs. We need to move on that. If we're poor at something, we need to train on something. Not exactly a revolutionary thought, but a lot of systems and a lot of managers do have a tendency to get stuck on that. And then have we adequately explained why we need to do it? And when I say when we need to do why, let's suggest that in the cardiac arrest analogy, the 14%, based upon our data and are looking at QA metrics, we've realized that we have time between compressions. We have times when we're off the chest for upwards of 20 seconds. And each one is each call individually. We don't know why. Maybe it's attempting to get an airway. Maybe it's changing compressors. Maybe it's moving a patient, but we're consistently showing these gaps in being off the chest of greater than 20 seconds. So we need to make sure that we're keeping that time off the chest to as close to zero as we can get it. But realistically, what we want to do is at least make sure it's less than 10 seconds if we have to be on off the chest. But have we adequately explained why we need to do why? Is this maybe an opportunity to put together some sort of training? The AHA has some stuff out there. A bunch of individual folks will have some stuff out there which says, hey, this is how compressions work. This is how the system gets pressurized while you're doing compressions. This is the graphs and the charts that show. It's not until you get to the 16th compression that you're actually starting to get that CPP up. That's actually starting to work. And everything before that is just building to that point. Have we adequately explained that? And that's how you get buy-in. You get buy-in by individuals being invested in their agency, in the QI process, in getting better because they want to be better. And you get people invested by explaining to them, hey, doesn't everybody want to save more lives? Well, yeah. Why are you here if not, is the question from the back. Yeah, for the statement, yes. But have we adequately explained that, hey, being off the chest for more than 20 seconds causes complete and total depressurization, thus essentially bringing us back to this whole pushing a rock up a hill thing. We're never going to get better unless we cut it out. Here's why. And you can watch the aha moment go off in people, and you're like, oh, I never realized how important it was. I always knew it was important, but now that I see it put together like that, I'm going to make it my life's work to have a 2-second off the chest time at all times. And I'd say 2 seconds, good luck with that, but I really want to see it and tell me how you've got it done. So how do we know if QI, anything that we've introduced in training and any of the QI improvements, how do we know if they're working? We know because we're going to measure that through QA. And you get to this great big cyclical nature that's not unlike this poor little guy who got trapped in his own shell. I love this. I apologize if you don't like snakes, but this is just funny to me. He's trapped in his own shed skin. Unfortunate. So everything feeds into itself. The Uberus effect, the whole QI feeds into QA, which feeds into QI, which feeds into QA. And the end result is ultimately better patient care, better provider buy-in, and overall a better culture for growth and learning. And it really does all start from having a strong and effective QA and QI program that avoids a lot of common pitfalls. So that comes in right at 45 minutes. Does anybody have any questions on anything that we just talked about?
No, sir.
All right.
Guys, we are done for today. Please thank Max for his time.
Thank you, Max, for your time.
Your contact info is on the front of almost every presentation, right?
No.
Okay.
Thank you, Max.
You're welcome. Yeah, it's on the last slide of the WMD one.
Okay, so if you take a question later today, just go back, we'll get the Zoom posted up tonight and on the YouTube channel. And then if you have questions, just text me and say, hey, I need Max's contact information. I got it. Still on his email and ask him or email him if you have a follow-up.
Everybody, thank you for your time. This is my first time teaching to a room full of disembodied voices. It's been a interesting experience for me. So hopefully the inflection and everything wasn't too painful for you guys. Best of luck. I know you've got tests coming up, so good luck with that. And thanks for taking our profession and pushing forward and making it a better place. And I look forward to living in the world that you guys create. So thank you so much and have a great day, rest of your day.
Thank you.
Martha, will you be here tomorrow? Martha, will you be here tomorrow?
Paging a Martha, will you be here tomorrow? Is the question from the back of the room.
That is yet to be determined. I'm trying to drive in traffic.
Okay, I'll call you later. Rob,
All right.
will you be here tomorrow?
Yes, I will be here. Be there.
Diane, are you present physically tomorrow?
No, I will not be. Sorry.
Okay, then I'll see you Friday, right?
Friday, yes, sir.
All right. And John, I know you won't be here. Where are you in the world today, John? John.
You can turn the mic on.
Oh. He lives in Western.
That's a far away.
Guys, we're going to stop the recording and we'll see you tomorrow or Friday.